AstraZeneca की है.
जी.
Okay, Dr. Timur, I think he's online.
जी.
Okay. चलो भैया.
खैर हाल है.
मेहरबानी जी, मेहरबानी. Thank you. Can you see me?
Okay, I'm going to start recording. Record on the
तो
cloud.
कितने लोग हैं फैसल? How many people have joined us?
We have 22 participants right now.
वजन लिहाज से पार्टिसिपेंट भारी हैं. डीन साहब, आरिफ साहब भी बैठे हुए हैं. ये वो तो it's the quality that counts, I suppose.
So, Dr. Timur, let's start. Bismillahirrahmanirrahim.
Sure. Assalamu alaikum, everyone. Today we are going to have our KPK Intraoperative Neurophysiologic Monitoring Workshop. Thank you, Dr. Faisal Jahangiri, Kim Khanna, Dr. Rashid Hanif, Dr. Amir Ghafur Khan, and all the distinguished speakers. And the purpose of today's initiative is that to introduce the intraoperative neurologic monitoring in Khyber Pakhtunkhwa province for the spine, brain, and ENT surgeons, and also allied surgeries. And कितनी important specialty है जिसमें we can do so much that has been prevalent over here. And also the great news is that we have leaders of this expertise with us today from Pakistan as well. And they're going to share their experiences. And we have leaders from both circles. And the important part of this initiative was that Khyber Medical College Alumni Association of the North America collaborates with Dr. Faisal Jahangiri, who is one of the very distinguished member of our alumni in North America, and is also a leader in the field and president of the Society of the Intraoperative Neurophysiologic Monitoring in North America, to create this awareness and to bring all the stakeholders on the one platform and look for the future leaders. And after this awareness, we can tap on all those areas of interest and explore the avenues where we can train them, collaborate with them, do some joint ventures. So without any further delay, I'm just going to introduce briefly all our distinguished panelists. We have Dr. Rashid Hanif, who is the president of the Khyber Medical College Association of the North America. He's a practicing gastroenterologist in Hagerstown, Maryland. We have Dr. Faisal Jahangiri, who is currently based in Dallas. As introduced, he's the president of the Society of the Intraoperative Neurophysiologic Monitoring, and he has distinguished career in training hundreds of people and inspiring them to pursue this career. And he's also have extensive background in taking out this expertise and taking it to the Pakistan and also to the Middle East. And we have Dr. Shahid Rafiq, who's a vascular neurologist in Frederick, Maryland, and been chair of the UPNA Merit, and he's the leader of the education in Pakistan, and who has done a lot of projects with UPNA and different institutes. And we are excited to have him with us. As we have Dr. Amir Ghafur Khan, who's a professor of gastroenterology and a very distinguished member of the Pakistani physicians who has extensive training background from UK, and is a leader in the KPK Health Initiative projects. And we have Dr. Arif Khan, who is the Dean of PGMI and Professor of Orthopedics. And we're looking forward to hear from him, from his expertise. Since I would just say a word that since I was a medical student, I've heard great things about him, and we are excited to hear him live today, who has extensive work done in KPK province for the patient's care. So Dr. Rashid Hanif would like to give you the podium to share your vision with us about this project.
Thank you, Taimur. That was a very nice introduction. So on behalf of the Khyber Medical College Alumni Association in North America, I want to welcome all the participants to the first online workshop on intraoperative neurophysiological monitoring. Frankly, until a few weeks ago, I was not aware of this specialty. I want to thank Dr. Faisal Jahangiri, a graduate of Khyber Medical College, who brought this to our attention and explained to us what this specialty is and how needed it is in terms of improving the outcome of patients' procedures, especially spine procedures, other neurological procedures in KPK particularly and Pakistan in general. It is an exciting new frontier for many places in the world who are not familiar with this kind of monitoring. I've been told that this can reduce the risk of complication by almost 100%. It is indeed my honor to have all these specialists here who will present the workshop, will present in the workshop. I'm thankful to Professor Arif, who's the Dean of PGMI, Dr. Shahid Rafiq, a prominent neurologist, and Dr. Amir Ghafoor from Leading Hospital, who has joined us, among many others. Our vision is to start teaching this modality online because of the COVID. Our volunteers may not be able to travel right away, but in the near future, once we can have travel arrangements made, we are hoping that we'll be sending 3 to 4 volunteers twice a year to KP, different hospitals in KP to actually demonstrate and do these procedures during different surgeries. And ultimately, as was proposed just a few minutes ago by Professor Arif, I think the goal would be to start a local diploma training course, both for physicians and technicians in KP. I think this is a very exciting new beginning for such a project in a field that has really not taken hold in KP, especially, and even the rest of the country. I think that today's program is an introduction to this field. I'm thankful to all the participants who registered and who are here today to attend this program. As we go along, we will develop more practical ways of teaching and imparting this education to our colleagues and students who are interested in this field. Certainly, I would appreciate that the local hospital, the local teaching hospital, especially KMU, they increase the awareness of the need for this field, and therefore we can have medical students and other physicians and technicians who would be interested in learning this field. We at Khyber Medical College, we've been involved in certain projects, and more recently, we have been running a intensive care unit online round for the last 6 months with collaboration with Leading Hospital and Dr. Amir Ghafoor, especially running the ICU rounds via telemedicine. And it has been quite effective. And we think that in this new day and age, when online teaching and online training has become a norm, as Professor Arif just mentioned, I think that we should avail this opportunity and use this to its maximum effect. So thank you again, and I will give the podium back to Taimur, our moderator.
Thank you very much, Dr. Hanif. So I think our next on the agenda is Dr. Arif, Professor Arif, shared his experience with us, intraoperative neurophysiologic monitoring as a spine surgeon, and the need for IONM to train doctors. Has he, I think he left the meeting, not sure. Let me see if we have.
More if his line is dropped, you could ask somebody else because
Sure.
obviously it's live. So when Arif,
Sure.
I'm here, Noor. I'm here.
Oh, okay. Sorry, sir. Maybe I think my screen is not showing up. So, Dr. Arif, we all just as we introduced, Dr. Arif is one of the very distinguished orthopedic surgeon and professor of orthopedics and dean of PGMI, Hyderabad, Peshawar. I would like to give him the podium and benefit all the audience from his great experience of KPK IONM monitoring. Over to you, Dr. Arif.
So, thank you, Noor. And first of all, let me express my gratitude to all of you, to Apna, to especially to Faisal Jangiri, because he has been very instrumental in developing this today's session. And I know his interest. I met him quite a few years ago, and he was here even at that time. He wanted to start the neuromonitoring in Pakistan, particularly in KPK, and that's how he came to our department. So, can everybody hear me?
Yes.
Hello?
We can hear you.
I think it looks like its name was disconnected.
There's something wrong with
Yeah.
this.
So
Something happening today, disconnecting again and again. So can you hear me now?
yes, we can.
Yes.
So I won't take long. This is been doing. We have started neuromonitoring in 2012 for our spine surgery patient, and we are using the Medtronic, the NIBS Eclipse system, surgeon-directed module. And at that time, and even now, we did not have any neurophysiologist here to support. So what we did was we made internal arrangement. And
I think we'll wait for a few minutes and maybe some connection issues with.
yes, I think connection is very, very unstable today. It doesn't happen like this somehow. So as I was saying, we are using the NIMS surgeon-directed module, and you all must be fairly familiar with it, all those who are using it. Dr. Fayaz is the main person who is providing us the arrangements, and he is the one who reads it, and I'm the one who are operating. And since 2012, we are using it. We have quite a few episodes where we found this very useful, and it helped us in protecting the patients. And at least I remember 2 cases where the neuromonitoring was very helpful, and we removed all the implants and we undid everything, and the patient, both of them, recovered. And most importantly, it reduces the stress of the surgeon. Those who have done spine surgery without neuromonitoring, they would know that the stress is enormous till the patient start using the limbs. And when you have the neuromonitoring on, you are very much relaxed and you know that everything is going fine. So since 2012, I would like to mention of the problems that we have been facing. As I said, we don't have the neurophysiologists, so expertise is one thing. We do not have that kind of expertise who can be very helpful. This is just a very superficial expertise that we are using to use our neuromonitoring system, but we need neurophysiology. Eclipse system. And
Professor Arif, we lost you. I think we lost your voice.
If Arif could switch off his video, maybe that would put less pressure on the, the system, and maybe he could present it.
Okay.
Arif, tasu lag video off ke kidishi aga bandwidth ay sar lag khashi. Taimur?
Ji sir.
Arif aate to we can in between talk. Shahid bhai bhi hai shayad.
Ji, I'm here.
आपका क्या ख्याल है? This is something we are very keen to progress. And Faisal Jahangiri is here. Do we really need a medical qualified person, or we could get a, biomedical person to be trained in this thing?
देखिए जो I was talking to Faisal, by the way. Faisal is the one also who introduced me when I started here. At that time, he was also in Maryland. And so since that, I have worked from, I think, 2009. So 10 साल हो गए. I am doing intraoperative monitoring in तो जो अमेरिका का मॉडल है वो ये है कि एक जो टेक्नीशियन है वो he or she goes into the OR जो ऑपरेटिंग रूम है, ऑपरेशन थिएटर, उसमें जाते हैं, और जो न्यूरोलॉजिस्ट है वो रिमोटली मॉनिटर करते हैं अपने कंप्यूटर पे या लैपटॉप पे. ये डिफरेंट कंट्रीज में डिफरेंट मॉडल्स हैं. कई कंट्रीज में सिर्फ टेक्नीशियन जो है वो कर सकते हैं. मेरे ख्याल कनाडा भी उनमें से एक है. लेकिन मैं समझता हूँ कि अमेरिका का जो मॉडल है उसको पाकिस्तान में रेप्लिकेट करना ज्यादा फिजिबल और ज्यादा बेहतर होगा, क्योंकि उसकी वजह ये है कि काफी कॉम्प्लिकेशन हो सकती हैं. और जाहिर है कि जो न्यूरोलॉजिस्ट हैं या न्यूरोफिजियोलॉजिस्ट वो ऑलरेडी इतने नहीं हैं पाकिस्तान. तो जब और जो एक न्यूरोलॉजिस्ट है वो जब मॉनिटर कर रहा होता है तो वो मोर देन वन केसेस मॉनिटर कर सकते हैं, क्योंकि वो प्रैक्टिकली खुद नहीं है इसमें. अब यहाँ पे पहले न्यूरोलॉजिस्ट जो हैं वो एट ए टाइम 10 या 12 केसेस मॉनिटर कर रहे होते थे. फिर जो है जो अमेरिकन एकेडमी ऑफ न्यूरोलॉजी और अमेरिकन एकेडमी ऑफ न्यूरोफिजियोलॉजी, उनकी कह लें आप रिफॉर्म्स आई 4 or 5 years ago, and they limited it to 3 or 4 जो है केसेस, कि एक वक्त में आप 3 या 4 केसेस से ज्यादा नहीं मॉनिटर कर सकते. न्यूरोलॉजिस्ट की बात करें. So in that respect also, if there are 4 technician or neurophysiologist in the operation theater और बाकी neurologist जो हैं बाहर से वो कर रहे हैं, I think that would be more safe. वो चूंकि neurologist जो हैं उनको एक background है neurophysiology की, उसमें तैमूर भी यहाँ है, उनको पता है कि EEG का, EMG का और जो है different waves. तो लेकिन जो उसकी एक टेक्निकल एस्पेक्ट है कि मशीन को किस तरह चलाना है, उसको जो इलेक्ट्रोड्स हैं वो कहाँ लगाने हैं, और मतलब डिफरेंट ऑपरेशन के लिए डिफरेंट इलेक्ट्रोड्स प्लेसेस, उसकी मोडालिटी क्या करनी है, मशीन शुरू किस तरह करनी है, मशीन खत्म किस तरह करनी है. तो वो चीजें और उसके साथ सर्जन के साथ ऑपरेशन थिएटर में नर्सिस के साथ कैसे कोऑर्डिनेट करना है, ये चीजें जाहिर है कि वो टेक्नीशियन बेहतर तौर पे कर सकते हैं, बेहतर जानते हैं। अब जिस तरह, और उसकी कोई लिमिट नहीं है कि जो बंदा अंदर ऑपरेशन थिएटर में जा रहा है वो you know they are really well qualified. Some companies here call them clinicians and some call them neurophysiologist or so they are really valuable. They in America they earn good money, they earn respect, and neurologists always respect them. We work as a team. तो मेरा ये ख्याल है अपना जाती कि वो ये वाला मॉडल पाकिस्तान में भी होना चाहिए, क्योंकि अभी मेरा ख्याल है दोनों की नीड है पाकिस्तान में। जो अल्टरनेटिव फील्ड है या जो एलाइड फील्ड है, हेल्थ केयर एलाइड फील्ड्स, वो भी मतलब हमें चाहिए कि और लोग चाहिए। मतलब उसमें फिजिकल थेरेपिस्ट आ गए, जो दूसरे टेक्नीशियन हैं डायग्नोस्टिक मोडालिटीज के। जी जी
शायद भाई इनके लिए तो, आपके लिए तो आसान है ना, बिकॉज दे विल हैव ईईजी टेक्नीशियंस, या जैसे एको के टेक्नीशियंस होते हैं, या जैसे हमारे एंडोस्कोपी टेक्नीशियन होते हैं, तो वी कैन वर्क ऑन द सेम मॉडल दैट वी गेट द टेक्नीशियन. Probably neurologist we can find, maybe we pitch it at a younger level, somebody who's just done his registrarship and this is the field he could step in. Ye Faisal hi batayega ki would, because this might ultimately lead to the development of neurophysiology services in Pakistan, which hamare paas nahi hai.
राइट, एब्सोल्युटली। उसमें जो ईएमजी के टेक्नीशियन, ईईजी के टेक्नीशियन, उनके ज्यादा। तो बाज़ औक़ात जब फील्ड शुरू होती है, अभी तो बहुत नया है पाकिस्तान में, जिस तरह बता रहे थे डीन साहब के, वो यूज कर रहे थे मेट्रॉनिक्स की जो ऑटोमेटेड मशीन है, वो यहाँ पे भी कई सर्जन यूज करते हैं, लेकिन उसमें लायबिलिटी जो है वो ज्यादा है कि मतलब देन you cannot interact with anybody. It's just the machine. If something goes wrong and surgeon is doing the surgery, then who can help him out? So the thing is that जिस तरह आप कह रहे हैं कि बाज़ औक़ात जब चीजें ना वो खुद रास्ता बनता है, कि जब आप शुरू करते हैं, देखते हैं क्या है लोगों का इंटरेस्ट, उनका लेवल क्या है। जाहिर है कि मैं भी फैसल के साथ आई एम इंटरेस्टेड। केपीके हमारा जो है वो होम है, हमारे पड़ोस में, मैं वाम कैंट में हूँ, तो थोड़ी देर बाद जो है केपीके शुरू हो जाता है। और एलआरएच के साथ तो हमारा खास राब्ता है मेरिट का और अपना का। तो जो है वो हम शुरू करेंगे इंशाल्लाह, उसमें देखेंगे कि लोगों का इंटरेस्ट क्या है, उनका लेवल क्या है। तो अगर आप जिस तरह कह रहे हैं कि अगर वो जिस तरह जो एलाइड फील्ड में, अब यही हमारी कोशिश है हर तरफ, मतलब फिजिकल थेरेपिस्ट में, नर्सिंग में, कि अगर वो बेहतर हो जाए ना, तो हेल्थ केयर जो पेशेंट केयर है, इट्स अ टीम एफर्ट। एक डॉक्टर अकेला जो है वो कुछ नहीं कर सकता, जितना भी टैलेंटेड हो। अब पाकिस्तान में जो टैलेंट, जिस तरह आप हैं, जीआई के स्पेशलिस्ट हैं, आई मीन माशाल्लाह, इट्स इमेंस टैलेंट। पाकिस्तान में जो फिजिशियंस हैं वो किसी से कम नहीं है, दे आर मे बी दे नो मोर देन मी। लेकिन जो मैंने देखा है, जो डिफरेंस है डेवलप्ड कंट्रीज में और थर्ड वर्ल्ड कंट्रीज में, वो है सिस्टम का, कि सिस्टम में जो एक टीम वर्क होता है, जिसमें नर्सेस को इज्जत दी जाती है, जिसमें टेक्नीशियंस जो हैं उनको इज्जत दी जाती है, जिसमें जितने भी पैरामेडिकल या हेल्थ केयर एलाइड पर्सनल हैं उनको इज्जत दी जाती है, और वो एक मिलके एक एज ए टीम पेशेंट को, उनका गोल एक ही है सबका, कि पेशेंट को अच्छा तरीके से
शायद
ट्रीट
भाई
करना।
ये मैं आपसे एग्री करता हूँ। देखें, आवर सिस्टम इज फिजिशियन डिपेंडेंट। आपकी बात ठीक है, आप जैसे काबिल लोग हो तो सिस्टम, लेकिन जैसे आप देखते हैं अमेरिका और ये जो डेवलप्ड वर्ल्ड है, देयर सिस्टम ड्राइव्स। अगर डॉक्टर से मिस हो जाए, नर्स उठा लेती है, नर्स से मिस हो जाए, टेक्नीशियन उठा लेता है, विच इज द सेफ्टी नेट। एंड वीव हैड राशिद बैठा हुआ है, वीव हैड, और आपके साथ भी, हमारे मेरिट के साथ भी बहुत बड़ा उससे फर्क पड़ा है कि व्हेन वी ड्रोव आईसीयू, you see that brought in lab changes, that even brought in changes from technicians की जी कितनी देर में blood sample पहुंचता है. तो I think we must drive this system. अभी फैसल को कहते हैं कि रियाज को कहे अगर वो बात करना चाहे, अगर
जी,
वो
so,
आरिफ
Dr. Amir, we have Dr. Arif back with us, you know.
चले आरिफ को कहे ना फिर आरिफ.
जी, Dr. Arif.
सॉरी तैमूर, पता नहीं यहाँ
No
पर
worries.
क्या प्रॉब्लम हो रही है, बार बार डिस्कनेक्शन आ रही है.
No worries.
तो व्हाट आई वाज टॉकिंग कि हमारे पास जो प्रॉब्लम्स हैं इसमें, एक तो ये है कि ह्यूमन रिसोर्स नहीं है, न्यूरोफिजियोलॉजिस्ट नहीं है हमारे पास, हमारे एनेस्थेटिस्ट है और मैं हम जितना कर सकते हैं, लेकिन वी नीड ट्रेनिंग. यहाँ पर कोर्सेज नहीं है, डिप्लोमा कोर्सेज नहीं है, डिग्री कोर्सेज नहीं है जहाँ पर आप लोगों को ट्रेन कर सकें. अब लोग तो बहुत ज्यादा हैं इंटरेस्टेड, जो कि आना चाहते हैं, लेकिन कोई उनको पढ़ाए तो सही. दूसरा ये है कि जो हार्डवेयर है, जो सिस्टम है, दैट इज एक्सट्रीमली एक्सपेंसिव. गवर्नमेंट उसमें इन्वेस्ट तो कर रही है. हमने सिस्टम 8 साल पहले खरीदा हुआ है, खैबर वालों ने ले लिया है. कई जगहों पर सिस्टम आ गए हैं, लेकिन रीड करने वाला कोई नहीं है. जहां पर आप जैसे लोगों की इंपॉर्टेंस आती है, जरूरत आती है कि आप लोगों को ट्रेन करें. अब इनिशियली न्यूरोफिजियोलॉजिस्ट का यहाँ पर होना शायद पॉसिबल ना हो, बट व्हाट यू कैन डू इज टू ट्रेन टेक्नीशियंस. यहाँ पर टेक्नीशियंस हैं जो कि ये न्यूरोफिजियोलॉजिकल स्टडीज तो करते हैं, नर्व कंडक्शन स्टडीज कर रहे हैं, EMG स्टडीज कर रहे हैं, बट दे आर नॉट यूज्ड टू द इंट्रा ऑपरेटिव न्यूरोमॉनिटरिंग. अगर आप उनको ट्रेन कर सकें, या फ्रेश लोगों को ले लें, उनको ट्रेन करें, और एटलीस्ट स्टार्ट फ्रॉम द टेक्नीशियन लेवल, टेक्नीशियंस को ट्रेन करें, एंड देन यू कैन ग्रेजुअली मूव ऑन टू मोर एक्सपर्टीज. और लोगों को भी जरा अंदाजा हो जाएगा कि दिस इज अ वायबल फील्ड वेयर दे कैन डेवलप देयर कैरियर. तो लोग इस तरह आना भी शुरू हो जाएंगे, उनको कॉन्फिडेंस भी आ जाएगी. तो दिस हाउ वी कैन मूव ऑन. अब आमिर यहाँ बैठा हुआ है, तो आई थिंक वी आर इन अ वेरी गुड पोजीशन टू स्टार्ट एनी सॉर्ट ऑफ कोर्स और डिप्लोमा और इवन मास्टर प्रोग्राम, whatever you recommend, आप यहाँ पर हम कर सकते हैं. And I would suggest कि आप इसके लिए एक हाइब्रिड मॉडल डेवलप करें कि आप वहाँ से ऑनलाइन कर सकें, हम यहाँ से जितना पॉसिबल हो इंस्ट्रक्टर्स ले सकें जो फिजिकली अवेलेबल हों. आई एम श्योर कि न्यूरोलॉजिस्ट, फिजियोलॉजिस्ट, दे कैन ऑल बी पार्ट ऑफ द टीम. तो अगर सारे मिलकर हम एक कोर्स ले लें एज अ पायलट और उसको आगे ले जाएं, आप कोलैबोरेशन डेवलप कर सकते हैं वहाँ पर जो अथॉरिटीज हैं, एजेंसीज हैं, या व्हाटएवर इट इज. अदरवाइज हमारा KMU है, who can be the degree awarding body. You want to have a certificate course, you want to have a diploma course, you want to have a master level course, whatever you want to. लेकिन अगर आप एक पायलट कोर्स ले लें और let's start working on it, और उसको अगर हम ले लें, तो that will bring a tremendous change. लोगों को अंदाजा हो जाएगा कि ये एक बहुत इंपॉर्टेंट चीज है और इसका यहाँ पर स्कोप है. आपको पता है यहाँ पर पॉपुलेशन ज्यादा है, अपॉर्चुनिटीज कम हैं. ये एक यूनिक अपॉर्चुनिटी होगी लोगों के लिए कि वो इस फील्ड में आ जाएं और to become the team leaders, because they will be here from the start. They will be the one leading.
ऐसे करते हैं ना आरिफ, ऐसे करते हैं, आप इसमें लीड ले. देखें, आपकी बात ठीक है, सर्टिफिकेशन आसानी से हो जाएगी. हम KPRA को भी ले लेते हैं, KMU को भी ले लेते हैं. यू हैव द इंस्ट्रूमेंट्स, हमारे पास तो LRH में नहीं है.
We have it. We can provide the place where they can all sit and they can do the training, and Faisal can develop the module कि करना क्या है. यहाँ पर लोकल आप रिसोर्सेज को आइडेंटिफाई करें, उनको हम कांटेक्ट कर लेते हैं. आपके जो न्यूरोलॉजिस्ट हैं मियाँ साहब LRH के, he is very keen on developing this. Ayazul Haq, if you know him. और
ऐसे करते हैं आरिफ, I have a suggestion. Taimur, you're listening. देखें, why don't we start doing this online? You monitor a few cases for them online, and that is how we do it. क्या ख्याल है?
जी, absolutely. फर्स्ट भाई.
जी हाँ, लेकिन आमिर, दिस इज नॉट द वे टू गो. 2-3 केसेस मॉनिटरिंग से तो मसला हल नहीं होगा ना. व्हाट वी नीड इज कि हम इसमें कोई प्रोग्राम शुरू करें.
मैं ये कह रहा हूँ कि देखें, we start doing it and then obviously it has to be developed. आप you can't go into certification straight away. आप केसेस तो कर रहे हैं ना, so let's get some advice and you develop it. हम भी बंदे भेजवा देते हैं, अयाज को भी इन्वॉल्व कर लेते हैं, रियाज बैठा हुआ है न्यूरोसर्जरी का आप, so we have something to start with.
But Amir, I don't think it can be started like that. देखिए ये तो हम टेक्नीशियंस की बात कर रहे हैं, वी आर नॉट टॉकिंग अबाउट डॉक्टर्स. डॉक्टर्स को अगर आप ले भी लेते हैं, कल को उनको कोई और कैरियर मिल जाएगा, वो चले जाएंगे. तो अनलेस के somebody is very keen on going into neurophysiology, और उनको हमने पहले बताना होगा कि this is viable option. आपने पहले टेक्नीशियंस को पहले आपने एनाटॉमी बतानी है, फिजियोलॉजी बतानी है, क्लासरूम्स में उनको ये चीजें पढ़ानी है. Gradually you have to bring them into the practical part of it. So it's not something that you can straight away start the OR.
Yes, isme I have already developed the module for like a 6-month program for
Yes.
physician, and there's a diploma program for technicians. So it's already planned and I'm running in US. So the same program I'm going to use in Pakistan, so we can do hybrid module, but as you are saying that mostly starting with online because of this current condition,
Yeah.
so we cannot do in classes, but a lot of lectures and discussions. And so as Professor Arif is saying, that we have to teach them about the basic anatomy, physiology, instrumentation, what are the electrodes, what are different type of electrodes, how to use them, and what are different type of surgeries. So I'm going to talk on my presentation after this. So what are the different modalities? So learning about sensory evoked potential, motor evoked potential, EMG, EEG. So basic knowledge before they go into the OR, because we don't want to take people into the OR, because taking the OR is already a high infection area. So you want to you are going to increase the rate of infection if you have more people walking there. So we want to take minimum people, but every single time they are in the OR, they get the maximum benefit. And the only way they are going to get the maximum benefit is they have the theoretical background and they are there to know, okay, how I'm going to apply this. So हम उनको ले जाके, we are not going to say, okay, they in the operating room and they say, okay, what we are doing and what we are going to do. So you're going to waste a lot of days, a lot of operating room time, but having a person have no idea what they are going to do. So the best way is like with current condition and everything, with all the technology we have, we can start. So one of the reasons having this an open public is forum is people who are interested on the physician side and technology side. We can ask them to step forward and we can talk to them and select people. And we need institutes. So Alhamdulillah, Dr. Arif, he is running the postgraduate institute. So we have a help from there, and with the institute from LRH and Hyderabad Medical Complex and so we can create an online program, and I have a platform, so we can without any cost.
In fact, you see, we at LRH have spoken to our chairman board of governors, who's based in USA, and he's very keen. And I think we're going to purchase the machine and get on with it. So let's see how. We'll keep you in the loop. और बात आपकी ठीक है, आरिफ जैसे कह रहे हैं कि टेक्नीशियन, तो आरिफ कहता है तो उससे बात कर लेते हैं, PHSA से बात कर लेते हैं. मैं वो
the way forward would be, let me summarize what we can do is, सबसे पहले तो फैसल जो मॉड्यूल आपने डेवलप किया हुआ है टेक्नीशियंस के लिए, वो आप शेयर कर लेंगे कि भी हमने इसको इतने टाइम में करना है, और ये हमारे टॉपिक्स होंगे जो हमने पढ़ाने हैं. फिर इसके बाद और ड्यूरेशन एंड व्हाटएवर यू नीड. फिर इसके बाद रिसोर्स पर्सनल आपने आइडेंटिफाई करने हैं, जो आपके ऑनलाइन आएंगे वो भी, और जो आपको यहाँ से चाहिए वो भी. उनको हम आइडेंटिफाई करके उनको हम लूप में ले लेंगे. करिकुलम जो आप डेवलप, इसका करिकुलम हमने डेवलप करना है. करिकुलम वो आपने डेवलप करना होगा. जो करिकुलम आप डेवलप कर लेंगे, वी विल प्रेजेंट दैट टू खैबर मेडिकल यूनिवर्सिटी and get approval from them, और इसको बाकायदा as a course advertise कर लेंगे. Once we get approved, certificate courses can be easily approved. तो वहां से एक दफा अप्रूव करके हम इसको एडवर्टाइज कर देंगे कि ये क्लासेस शुरू कर रहे हैं, ये इसका स्कोप ऑफ वर्क है, ये इसकी लिमिटेशंस हैं, ये कुछ होगा. And we will get the people enrolled in it. हम उनको फैसिलिटीज देंगे, क्लासरूम, टीचिंग, जो भी है वो सारी फैसिलिटीज हमारे पास PGMI में मौजूद हैं. वी विल प्रोवाइड यू ऑल द फैसिलिटीज ऑनलाइन एज वेल एज फिजिकल. तो इसी तरह ये एक शुरू हो जाएगा. यू विल आइडेंटिफाई कि क्या पढ़ाना है, कब पढ़ाना है. यू वांट टू हैव क्लासेस एवरी डे, यू वांट टू हैव इट once a week, you want to have it लाइक जिस तरीके से भी आप करना चाहते हैं, आजकल हमारे पास हो रही है यहाँ पर सर्टिफिकेट इन हेल्थ एजुकेशन, जो कि महीने में 5 दिन क्लासेस होती हैं, एंड देन दे हैव असाइनमेंट्स, एंड सो दे कीप गोइंग इट फॉर लाइक 3 months, इसके बाद एग्जाम होता है। तो यू कैन डू द सेम मॉड्यूल, और यू वांट टू हैव अ डेली क्लासेस, वो भी आप कर सकते हैं। तो जिस तरीके से हम इसको डेवलप कर लेंगे, उसको आगे इस तरह लेके जाएंगे, and then you can have assignments, you can have assessments, and after a certain point where they think now they are safe and they understand the theoretical part of it, then we can gradually move them towards the OR. इससे पहले हम उनको डमीज पर सिखा सकते हैं, उनको इससे पहले हमारे पास डमीज हैं, वहां पर इनको हम हाउ टू अप्लाई लीड्स, हाउ टू टेक द डू द बेसिक्स, वो हमको हम लैब में करा सकते हैं। ये सारी चीजें करके फिर हम उनको OR में ले जा सकते हैं, and from there then the things will become more clinical. So this is what my idea is, कि this is more practical to do it this way, बजाय ये कि हम कुछ 5-6 लोगों को ले लें। इस तरह हमारे पास एक पूरी क्लास आ जाएगी, 30, 35 whatever you suggest, वो लोगों की आ जाएगी, और वो क्लास फिर आगे लीड करेगी, उनको हम फिर नेक्स्ट हायर प्रोग्राम में भी एडमिशन दे सकते हैं, मास्टर लेवल में भी लेके जा सकते हैं, जिस तरह आप सजेस्ट करेंगे अकॉर्डिंग टू द सर्कमस्टांसेस एट दैट पॉइंट। अगर आप इसमें कोई और तरीका,
अरे ऐसे करते हैं ना, लेट्स डिसाइड हियर एंड नाउ, आप एक क्लास का नंबर डिटरमिन कर लें कि वी हैव से 25 बंदे या 30 बंदे, उसमें से 10 LRH को दे दें, 10 उसको दे दें, 10 और अस्पतालों को दे दें, लेट्स गेट ऑन विद इट। क्या ख्याल है?
इसको ओपन छोड़ेंगे, वी विल एडवर्टाइज इट, एंड whoever wants to join, they should join, and उनको हम ये बताएंगे कि भाई your jobs are guaranteed because there is no one in the whole country having this sort of qualification and there is an enormous need for it. तो लोग आएंगे, एक दफा आ जाएंगे, then we will be providing them jobs. हमारे पास भी jobs हैं, आपके पास भी होंगी, खैबर में भी होंगी, हर दफा हर जगह पर जहां पर न्यूरो सर्जरी, स्पाइन सर्जरी हो रही है, वहां पर जॉब्स हम क्रिएट कर लेंगे इनके लिए, they will join and then they will move on.
Can I say something? I think that what Dr. Arif is saying seems to be the right way of doing this. If we can somehow establish a working group of leaders based in Peshawar, मतलब Arif हो गए, Khyber से हो गए, Reading से हो गए, 3 or 4 group, and they can work with Faisal Jahangiri, work the details out, and get it ready to present it to KMU. Once KMU approves it, you can advertise it, and so on.
Yes, or Faisal, I can send you a copy of one of the master program, the curriculum that we have developed. So you can develop a curriculum on a similar pattern, because that's how KMU will accept it. उस पर आप curriculum बनाकर 6 months का curriculum बनाकर, 6 months का आप बनाना चाहते हैं या 1 year का बनाना चाहते हैं, whatever you suggest, वो बनाकर वो आप हमें भिजवा दीजिए, वो हम प्रेजेंट कर लेते हैं KMU को, और एट द सेम टाइम आप हमें रिसोर्स पर्सनल का भी आइडेंटिफाई कर लें। अगर आप लोगों को नहीं जानते तो आप हमें ये बता सकते हैं कि वी नीड न्यूरोलॉजिस्ट, 2 or 3 न्यूरोलॉजिस्ट, हम उनको इंगेज कर सकते हैं। इफ यू वांट फिजियोलॉजिस्ट, हम उनको इंगेज कर सकते हैं। व्हाटएवर यू वांट, आप उनके हमें कैटेगरी बता दें, हम उनको इंगेज कर लेंगे। So I think we can do all this in a month time, and we can start the program in March.
नहीं, that will be very helpful. अगर आप मुझे वो उसका भेज दें KMU का जो है प्रोसेस, क्योंकि प्रोग्राम तो मैंने पहले से डेवलप किया, लेकिन I will mold into that position so it's approved for the और इसमें हमें जो फिजिशियन साइड पे हैं, द गुड थिंग इज इट्स ओपन टू एवरीवन, सो न्यूरोलॉजिस्ट के लिए इजी होगा, मगर एनीवन with no neurology background can apply for that. Even ENT, general physicians, surgery, orthopedic, neurosurgery. So koi bhi hai with a medical. So we are going to develop 2 programs. One is for physician and one is for technologists. We need both of them because it's difficult to have one physician in every operating room, lack of availability. So one physician will be, as Dr. Shahid Rafiq was saying, supervising multiple. So we will have better, more coverage for different type of surgery. At the same time, if we have like 4 or 5 technicians working in different rooms, and we have 1 or 2 neurologists, they are covering on those surgeries. So
Yes, message
as
from
जी,
Mustafa Khan, आपने देखा उसको?
so I'm
इसको?
head of neuro. Yes, sure, inshallah. तो जिस तरह हम we are doing the program, doctors के लिए है, medical college में they go for anatomy physiology before you go to hospital. They are not even go to hospital. So हम जो है उस तरह basic यही है कि theory knowledge है, then they go to medical college में, they're 5 years, so they go for anatomy physiology and maybe 1 week in the hospital, and 3rd year they start going and shadowing, and 4th year they are really hands-on, and 5 years finally. So we are not going for 5-year program, we are going to 6 to 1 month 12 month program. Magar it will be the same thing. So we are going to take them to the operating room. So zaruri nahi, we can show them like surgery in progress, and agar aap paas dummies hain, or that will be great. Second step is practice on dummy, how to practice before practice on, or live volunteers, then we can practice, they can practice on live volunteer. And also we can take to the empty operating room. What is the operating room? What is the sterile field? Because that's very important thing. Okay, what is sterile field? How to stand? How far you can to stand? Like 18 inches is the minimum requirement, international standing. So you don't turn back. This is don't touch the surgeon, don't touch the patient once everything is there. So all those things will be here like 1 week minimum training. Here people can go forget about that again and again. So all this is, and then Magar, at the same time, we are going to go the hands-on training from the day one, computer programming, the software programming, electrode setup on a dummy. So Magar, they cannot do setup unless they have no idea what they're setting up for. If they're doing motor evoke potential, what is a motor evoke potential? How to stimulate, how to record. So those log hain, they want, I think, let them speak. Dr. Riaz and Colonel Talha and Mateen and Dr. Mustafa. He's also head of neurophysiology from ZMU. So I think I'll like him to talk for 5 minutes. So then I'll do my presentation and then come back to question answer. So once I do presentation, then people will have more idea that what we are talking about. Dr. Mateen.
Dr. Farooq Mateen.
Dr. Farooq Mateen is the director of neurophysiology program in Shifa, and he's been involved.
He said he'll be back in 20 minutes. So
That was Dr. Talha.
okay.
We have Dr. Riaz from Leading Hospital Neurosurgery.
Dr. Riaz, if you're online, please, we like to get up. If you can say a few words. Okay.
Hello.
Assalamu alaikum.
We have Dr. Riaz Rahman. Yes. Dr. Riaz, we can hear you.
Hello. Give me 1 minute.
Sure.
1 minute, please. Hello.
Ji, Dr. Riaz.
Assalamu alaikum everyone.
Walaikum salam.
बस बात तो हो गई है. आमिर गफूर साहब ने तो हमारी बिहाफ पे बात कर ली है लरिश से. हम न्यूरो सर्जरी डिपार्टमेंट से हैं और न्यूरो मॉनिटरिंग का हमने मॉनिटर का ऑर्डर दिया हुआ है. चेयरमैन साहब ने इसको प्रायोरिटी लिस्ट पे रखा हुआ है. इंशाल्लाह चंद एक महीनों में आ जाएगा. तो बात वही है, हमारे पास एक्सपर्टीज का भी इशू है. इसमें मेरी एक सजेशन है कि ये जो ट्रेनिंग हम डिप्लोमा वगैरह अनाउंस करें तो ये ओपन हो हर बंदे के लिए, वो मेडिकल ऑफिसर्स के लिए भी ओपन हो, रेजिडेंट्स के लिए भी CME मार्क्स हो इसमें, ताकि उनका इंटरेस्ट इसमें डेवलप हो सके। और टेक्नीशियंस ऑफ कोर्स, टेक्नीशियंस एनेस्थीसिया के लोग, तो इसमें हमारे पास जल्दी एक पूल आ जाएगा। और अभी इस तरह के अभी काफ़ी सारे मेडिकल ऑफिसर्स हैं जो जॉब की तलाश में, तो एक दफ़ा हम इनको ट्रेनिंग दे दें और इनको 6 महीने का या 3 महीने का या जितना भी हो प्रैक्टिकली डूएबल हो, और वो रजिस्टर और मॉनिटरिंग बॉडीज है। हमारे पास PGMI साहब तो बैठे हुए हैं और KMU भी है, तो मतलब इनको प्रॉपर सर्टिफिकेशन मिले और फिर पोस्ट है तो इंशाल्लाह फिर अगर हमारे पास एक्सपर्टीज तो वो भी एडवर्टाइज हो जाएंगी। लेकिन मैं समझ रहा हूँ कि काफी सारे मेडिकल ऑफिसर हमारे पास है वेटिंग, तो हम साल आधे में बहुत जल्द, तो मैं इसका कोर्स काफी एक्सपेंसिव है। इस सिलसिले में अगर हम कोई डूएबल ऑप्शन हो दरमियान में, किसी के पास कोई आइडिया हो, क्योंकि सरकारी अस्पतालों में जो लोग आते हैं वो तो ज्यादा फूडिंग नहीं होते हैं और एक पेशेंट पे तो इस पे काफी सारा खर्च आता है। हमारे पास अगर कोई ऐसा डूएबल अल्टरनेट हो, शायद इससे भी हमें फायदा हो सके। बस मैं सिर्फ इतना कहना चाह रहा था। थैंक यू वेरी मच।
जी, thank you very much, Dr. Riaz. I think we have Dr. Talha back. Colonel Talha.
Yes, I'm available. Can you listen to me?
Yes, we can hear you. Yes.
अस्सलाम वालेकुम, मैं डॉक्टर कर्नल तलहा हूँ एंड एक मैं जरा अपना कैमरा भी ऑन कर दूं। अच्छा, मैं बीच में मुझे जाना पड़ गया, जिसकी वजह से मैं पूरी बात तो नहीं सुन सका, लेकिन जो डिस्कशन है वो यही है कि हम इस चीज़ को कैसे यहाँ पे पाकिस्तान में शुरू कर सकते हैं। हमने 2015 में ये IONM का प्रोजेक्ट शुरू किया था CMH रावलपिंडी में, और उसके बाद से अब तक हम उसमें हमने तकरीबन 300 प्लस केसेस डिफॉर्मिटी स्पाइन सर्जरी के साथ किए। अब न्यूरो सर्जरी वाले भी इस फैसिलिटी को यूज कर रहे हैं। बट इसमें जो प्रॉब्लम्स आई वो साथ साथ मैं आपको बताता जाता हूँ, सो दैट आपको समझ में आ जाए कि ये जो आप जितनी भी बातें अभी तक कर रहे हैं इसमें मसाइल क्या हैं। सबसे पहली बात ये है कि जो यहाँ पे मैक्सिमम यूटिलिटी हो सकती है वो न्यूरो सर्जन्स जब तक इसको यूज ना करें तब तक इसकी यूटिलिटी मुश्किल है। बिकॉज स्पाइन सेंटर्स जो डिफॉर्मिटी स्पाइन सर्जरी करते हैं वो पाकिस्तान में अभी तक बहुत थोड़े हैं, और पाकिस्तान में हर स्पाइन सेंटर जो भी डिफॉर्मिटी स्पाइन सर्जरी कर रहा है, जैसे प्रोफेसर आरिफ का सेंटर है पेशावर में, हमारा CMH में है, या CMH में हमारे बाकी कलीग्स जो पिंडी में कर रहे हैं, उनके पास ये किसी न किसी फॉर्म में मौजूद है। जब तक न्यूरो सर्जन इसको यूज नहीं करते, क्योंकि मैक्सिमम बल्क ऑफ सर्जरी जिसमें न्यूरोलॉजिकल डेफिसिट के चांसेस होते हैं वो न्यूरो सर्जन करते हैं। स्पाइन सर्जन अभी जो ऑर्थोपेडिक के बैकग्राउंड से हैं वो कम है। तो सबसे पहले तो प्रॉब्लम ये आती है कि ज्यादातर लोगों को इसका अंदाजा नहीं होता कि ये क्या चीज है बेसिकली। 2014-15 में जब हमने शुरू किया था तो मेरे जो उस्ताद हैं जनरल असद कुरैशी, उन्होंने मुझसे कहा कि यार ये हमने करना है क्योंकि मशीन हमने ली हुई है 4 साल से और हम इसको यूज़ नहीं कर रहे, वी नीड समबडी हु कैन यूज़ द मशीन, तो आप ये करो। मैं उस वक़्त स्पाइन में नया-नया आया था, तो मैंने उनसे कहा सर ये मेरे लिए तो बड़ा मुश्किल है कि मैं स्पाइन सीख रहा हूँ और अब मैं भी साथ में ये एक बिल्कुल नई चीज़ है, इसका तो मुझे कोई आइडिया ही नहीं है, मैं तो सर्जन हूँ। तो उन्होंने कहा नहीं, जो चूँकि हमने आगे ये काम करना है और प्रॉब्लम भी होगी, इसलिए यू शुड गो एंड लर्न। उन्होंने मुझे हौसला देने के लिए कहा कि जस्ट लाइक जैसे ये ईएमजी, एनसीएस करते हैं, तो जाओगे यार बस वो नीडल्स वगैरह लगाते हैं, वो सीख के आ जाओ। तो मैं ऑल्दो मैंने 2 एफसीपीएस किए हुए हैं और स्पाइन सर्जरी भी कर रहा था। मैं चला गया, मैंने कहा सऊदी अरब जाते हैं, डॉक्टर रियाज़ जहांगीरी वाज़ वेरी काइंड, उन्होंने कहा आ जाइए मैं सिखा देता हूँ। मैं जब इनके ऑफिस में एंटर हुआ तो इनकी डिग्री लगी हुई थी, डिप्लोमेट अमेरिकन बोर्ड ऑफ इंटर ऑपरेटिव न्यूरो मॉनिटरिंग। सो वो डिग्री देख के मैं पहली बार मुझे पता लगा कि हम किस चीज़ के अंदर स्टेप इन कर रहे हैं। दिस इज़ समथिंग बिग, दिस इज़ नॉट जस्ट लाइक पुटिंग नीडल्स एंड गेटिंग अ रिजल्ट, इट इज़ समथिंग मच मोर देन दैट। खैर बहरहाल हमने वहाँ पे स्टार्ट लिया, वापस आया मैं ऑनलाइन डॉक्टर जहांगीरी से मैं रहा इसमें इन्वॉल्व रहा, जो मुझे प्रॉब्लम्स होती थी ऑनलाइन, इनसे मैं कंसल्ट करता था, पिक्चर्स भेजता था, जैसे भी था। एंड वी हैव डन सो फार 300 केसेस। लेकिन नेक्स्ट प्रॉब्लम जो ये आती है कि जो सर्जरी वाले लोग हैं, ये काम नहीं कर सकते। मैं स्पाइन सर्जन हूँ, मैं स्पाइन सर्जरी करूँगा या न्यूरो मॉनिटरिंग करूँगा, दिस इज़ नॉट पॉसिबल। प्रोफेसर आरिफ के पास जो सिस्टम है, वो सर्जन डिपेंडेंट है, लाइकली वो यूज़ कर रहे हैं, लेकिन हमारे पास जो सिस्टम है, उसके लिए यू नीड अ टेक्नीशियन और अ डॉक्टर जो उस पे बैठे और उसकी सारी फाइंडिंग्स को इंटरप्रेट करे। सो 1 साल तक मैं अकेला करता रहा, फिर मैंने एक असिस्टेंट अपने लिए ढूँढा, वो भी मुश्किल से मिलता है इसलिए कि नोबडी इज़ विलिंग टू कम इनटू दिस स्पेशलिटी टिल नाउ। तो उसको हमने ट्रेन किया, ही इज़ अ टेक्नीशियन और अब वो फुली खुद ही करता है। ही इज़ इवन नॉट अ डॉक्टर, लेकिन ये कि उसने इतना इंटरेस्ट लिया और हमने उसको बाहर भी भेजा। डॉक्टर जहांगीरी हैज़ बीन काइंड, वो उनसे कंसल्ट करता है। एक हमारे और पाकिस्तानी डॉक्टर साहब हैं, डॉक्टर तारिक इम्तियाज़, ही इज़ आल्सो अ डिप्लोमेट इन IONM, वो बड़ी हेल्प करते हैं हमारी। तो हमने एक सिंगल पर्सन को अभी तक हमने ट्रेन किया है, जो कि ये मॉडलिटी यूज़ करा रहा है। फिर हमने सोचा कि हम क्यों ना किसी और स्पेशलिटी को इसमें इन्वॉल्व करें। सो हमने रिक्वेस्ट की रिहैब वालों से, जो ईएमजी एनसीएस करते हैं। हमने कहा सर आप आएँ, ये स्पेशलिटी है, नई डेवलप करें, इसको सारा कुछ करें। बट ना तो रिहैब वाले लोग राज़ी होते हैं, ना न्यूरोलॉजिस्ट या न्यूरोफिजिशियन राज़ी होते हैं कि वो 6 घंटे, 8 घंटे ऑपरेशन थिएटर में बैठे रहें और उसके बाद आपको एक रिपोर्ट दे के चले जाएँ कि जी एवरीथिंग हैज़ बीन फाइन। हर एक की अपनी प्रैक्टिस है, जहाँ से वो फाइनेंशियली साउंड होते हैं। IONM उनको इनिशियली कोई फाइनेंशियल रिटर्न नहीं दे रहा। इस वजह से कोई ज़्यादा लोग इसकी तरफ आने को तैयार नहीं होते। फिर नेक्स्ट स्टेज में हमने कहा हम अपना एक बीएस प्रोग्राम शुरू करते हैं इसके लिए, IONM के लिए। अब बीएस प्रोग्राम शुरू करने के लिए भी उसके प्री रिक्विजिट्स हैं, वो हमने अपना एक 2 साल का कोर्स भी बनाया है कि हम शायद कोई फेलोशिप टाइप प्रोग्राम शुरू कर सकें। बट स्टिल वो भी नहीं काम कर सके, इसलिए कि उसकी प्री रिक्विजिट है, एफएससी के बाद आप शुरू कर सकते हैं कि नहीं। डॉक्टर कोई राज़ी हो इसमें आने को कि नहीं। फिर ये कि जो डॉक्टर आप हायर करेंगे IONM की ट्रेनिंग के लिए, उसको आप पे कैसे करेंगे? उसको बाद में क्या फ्यूचर दिखाएँगे कि जी पाकिस्तान के अंदर क्या इसकी यूसेज है, बिकॉज़ टिल नाउ अभी भी जो हमारे न्यूरोसर्जन कोलीग्स हैं, वो ये यूज़ नहीं करते या उनके पास है नहीं फैसिलिटी। तो मेनली स्पाइन सर्जरी वालों के पास ही है ये, जो लोग ये काम करते हैं, जहाँ तक मुझे अभी तक नॉलेज है। तो ये सारी प्रॉब्लम्स हैं कि पाकिस्तान के अंदर अभी भी जो यंग लॉट है, जो डॉक्टर्स हैं, उनको भी अभी इसमें कोई फ्यूचर नज़र नहीं आता। मैंने कई लोगों से बात की है, फाइनल ईयर की क्लासेस से बात की है, बट अभी तक वो इस तरफ आने को तैयार नहीं है, बिकॉज़ उनको इसमें कोई ओपनिंग एज़ सच नज़र नहीं आती। इवन अगर मैं उनसे ये कहता हूँ कि जी आप यूएसए चले जाएँ इसके बाद, तो उसपे भी वो दे आर नॉट वेरी कीन। वो अभी भी मेजर स्पेशलिटीज़ की तरफ जाना चाहते हैं। मेबी नई जनरेशन आए तो कोई चेंज आ जाए, पर अभी तो ऐसे ही है। अब सर कोई सवाल पूछें तो मैं जवाब देता हूँ।
Jahangir, bilkul, I would totally support Talha's statement. Talha ने जो बात की ये ground realities हैं यहाँ पर, और इसलिए मैं suggest कर रहा था कि ये BS program would be more practical. डॉक्टरों के लिए अगर हम शुरू करेंगे तो डॉक्टर को एक कैरियर देना पड़ेगा, और फिलहाल उनको वो कैरियर नजर नहीं आता इसमें, इसलिए उनका आना जरा मुश्किल होगा. अगर आप BS प्रोग्राम शुरू कर लें तो BS में हमारे पास लोग बहुत सारे हैं और उनके पास एक जॉब की अट्रैक्शन होगी कि हमें जॉब मिल जाएगी, तो दैट विल बी सफिशिएंट फॉर देम, तो वो उसमें आ जाएंगे. I think let's start with the BS program and then we should move on to much higher programs.
डॉक्टर तला, आप जो कह रहे हैं अभी सिचुएशन इम्प्रूव हो रही है, क्योंकि एक तो इसकी अवेयरनेस बढ़ रही है. अभी मेरे पास जो हैं डॉक्टर्स हैं जो डिफरेंट सिटीज फ्रॉम पाकिस्तान है, दे वांट टू लर्न IOM, वो मुझे कांटेक्ट कर रहे हैं और बहुत से एनरोल हैं, दे आर एनरोल इन पाकिस्तान फ्रॉम पंजाब, KPK, सिंध. So they are doing online learning for interpretive monitoring from live from Pakistan right now. So अभी मैं उनका नाम, I don't want to say the name right now unless they want to advertise themselves. मगर like I have like technicians and physicians or without neurology background, so don't need to have a neurology. I have a spine surgeon, I have internal medicine, I have rehab, and I have neurologists. So they are learning on doing the fellowship with me online. पाकिस्तान, तो ये तो अभी मैं US में कर रहा हूँ, US की कॉस्ट भी ज्यादा है. तो if you so one of the reason to have this meeting is to make an awareness for this is a career field which is can be achieved, क्योंकि पाकिस्तान में भी इतनी अवेयरनेस नहीं है इंटरप्रेटर, स्पेशली KPK प्रोविंस में. KPK में बिल्कुल नहीं है, बहुत ही कम है थोड़ी सी है. आई थिंक प्रोफेसर आरिफ जो है वन ऑफ द वो सीनियर मोस्ट पर्सन है जो दे आर यूजिंग दिस मॉनिटरिंग फॉर many years. लेकिन बाकी लोगों को तो हम as a field, even the students, current medical students or resident house job, this is like subspecialty which has a much benefit. So और सिर्फ spine surgeon, neurosurgeon जो है, technically US में spine surgeon takes most of the chunk of the neuro monitoring. Neurosurgeon is smaller than the spine surgeon because spine surgeon have all the cervical cases, thoracic cases, lumbar cases, scoliosis, shoulder, hip, joint. So every single surgery where the nerves are at risk. So anyway, I'm going to still have started my presentation. So I don't want to take much time. So हमारे पास 2-3 लोग हैं और they want to talk. So after that, I'm going to talk.
Yes, we have Dr. Sajjad Ali, who is a CCT neurophysiology from UK. I had a pleasure of seeing him many times in Pakistan Society of Neurology meeting, and he's a leader in teaching neurophysiology education in Pakistan. Dr. Sajjad. I think we lost him. Dr. Sajjad.
वो ऑनलाइन नहीं है अभी.
नजर तो आ रहे हैं लेकिन that's fine. We can wait to see if we have anyone else from the panelists. Dr. Amir has already spoken. Anyone from the CMH who wants to share their background other than Dr. Talha or CMH Pindi?
So Dr. Mustafa Khan want to say something from Karachi.
Yeah.
And Dr. Farah Mateen after that. Dr. Mustafa. Dr. Mustafa.
Yes.
Assalamu alaikum.
Walaikum assalam, Dr. Saab. How are you?
Thank you. Please, can you introduce yourself and share?
Right. Dr. Jahangiri, I have met you in Saudi Arabia as well, if you remember.
Okay.
So, so I was working in the King Faisal Hospital, and we have the 3 technologists there who have been done their CNIMs, and they are back here in Pakistan now. And I'm back also in Pakistan since morning. So I'm the head of the neurophysiology department, Ziauddin University here in Karachi, and we are conducting the BSMT program here in neurophysiology, and that program also include the training a course, a semester or whole semester on the CNIM. So we are training almost right now. We have approximately 23 students altogether of the 4 years, and ultimately after this is the fourth year. The first batch will pass out in this year, and we have the 5 students in that one. So we are training the neurophysiology technologists here in the IOM as well, but IOM as a course there, not the pure IOM. And that is the reason कि अभी मैं ये चाह रहा था कि अगर हम किसी तरह से पार्टिसिपेट कर सकें इन प्रोग्राम्स में आपके साथ और ट्रेनिंग में मदद कर सकें. सर, my opinion is very clear. I agree with everybody who has said so far. मेरे ख्याल में डॉक्टर आरिफ से भी मैं ये रिक्वेस्ट करूंगा कि हमें यहाँ पे BS ट्रेनिंग प्रोग्राम को स्टार्ट करने से पहले अगर हम छोटा कोई कोर्स स्टार्ट करें, लेकिन दैट शुड बी विद फॉर दोज पीपल हु आर ऑलरेडी डूइंग द BSMT प्रोग्राम्स. आई थिंक BSMT प्रोग्राम्स पंजाब में भी हो रहा है, KPK में भी हो रहा है. अभी डॉक्टर फरूक मतीन का आपने नाम लिया था. ही इज आल्सो कंडक्टिंग दैट प्रोग्राम हियर इन कराची. वी हैव वन प्रोग्राम इन द ज़ियाउद्दीन मेडिकल यूनिवर्सिटी. एक ट्रेनिंग प्रोग्राम आखान यूनिवर्सिटी में होता है. आई हैव वर्कड इन द आखान यूनिवर्सिटी फॉर 24 years actually. So the people are here. I think we just need the persons like Dr. Jahangiri to support us from abroad or something like that. So हम इन प्रोग्राम्स को यहाँ पे बहुत ज़्यादा strengthen कर सकते हैं. मेरी opinion ये है कि we have the human resource available here in Pakistan to start this program for the technologists at least, and simultaneously. देखिए सर, मैं आपको छोटे से एग्जांपल बताऊं. हमारे पास जो फेलोशिप प्रोग्राम्स होता है न्यूरोफिजियोलॉजी का, उसके अंदर जो फेलोज होते हैं उनको भी IOM में हम ट्रेन करते हैं यहाँ पे. बट दैट इज अ पार्ट, बहुत छोटी सी चीज है वो. अभी हम जो बात कर रहे हैं, इफ वी मेक एन स्ट्रक्चर्ड प्रोग्राम फॉर देम और द टेक्नोलॉजिस्ट. आपकी बात बिल्कुल सही है डॉक्टर साहब कि यहाँ पर फिजिशियंस, न्यूरोफिजियोलॉजिस्ट या कोई लोग अभी उनकी माइंड सेटअप नहीं है कि दे वांट टू बी टू मेक दिस IOM एज देयर कैरियर. अभी माइंड सेटअप नहीं है यहाँ पे लोगों के पास, तो इट विल टेक टाइम. लेकिन सर्विसेज को इम्प्रूव करने के लिए, हेल्थ केयर को इम्प्रूव करने के लिए टेक्नोलॉजिस्ट को ग्रूम कर लें थोड़ा सा, और टेक्नोलॉजिस्ट को ग्रूम करने के साथ साथ फिर हम इस प्रोग्राम को थोड़ा सा आगे बढ़ाएं, तो प्रोबेबली वी कैन डू अ लॉट. तो हमारे पास यहाँ पे इस वक्त पाकिस्तान में, मुझे एग्जैक्टली तो नहीं पता कितने हैं CNIM ट्रेंड, बट आई हैव द 3 people in with me. So that is what my ऑफर टू ऑल ऑफ यू कि अगर हम डॉक्टर जहांगीरी के साथ मिलके या डॉक्टर इम्तियाज के साथ मिलके अगर कोई प्रोग्राम यहाँ पे स्टार्ट करें टेक्नोलॉजिस्ट के लिए, ताकि वो एटलीस्ट हेल्प कर सकें. एंड अभी जैसे डॉक्टर साहब बता रहे थे, कर्नल साहब की जी, ही हैज बीन ट्रेन, तो सॉर्ट ऑफ दैट guys can help those technicians to start this services here in Pakistan. And it is very much demanding. I'm telling you, यहाँ पे मैं कराची में हूँ, मैं आपको यहाँ का बता सकता हूँ कि we have so many cases, and especially जो scoliosis के cases हैं, spine के cases हैं, even surgeons want resection of tumors के अंदर जितने surgeons काम कर रहे थे, they want these services here. Unfortunately it's not available. अभी लाहौर में एक डॉक्टर साहब ने स्टार्ट की है IOM, जिसमें वो राइजोटोमीज कर रहे हैं. वो तो मेरा सिर्फ आप लोगों से ये रिक्वेस्ट होगी कि अगर आप लोगों को किसी भी किस्म की हेल्प हमारी तरफ से चाहिए होगी, तो वी कैन प्रोवाइड यू द हेल्प इन दैट वन. तो बस मुझे इतना ही कहना था सर.
थैंक यू वेरी मच. आपका बहुत बहुत I'm very happy कि पाकिस्तान में CNM है. So I'm going to talk about CNM. So CNM is a certification which is a bachelor degree certification. So if you are a physician or a technologist, so that's the first certification you have to take in US, certification in neurophysiological intraoperative monitoring. So if you have a minimum of bachelor degree, you can qualify to that. So having 3 CNM certified in Pakistan is like great news. उसके बाद फिर डॉक्टर लेवल पे if you have a PhD, MD, then you can take American Board of Neurophysiological Monitoring. Like uske liye you have to have a 3 years of experience and 300 surgeries. Then you take oral exam and written exam.
Dr. Faisal, we have
Yeah.
Dr. Farooq Mateen from Shifa.
Okay, thank. Dr. Farooq Mateen is the director of neurophysiology in Shifa, so he's a very good friend and be in contact. A few words. You're muted. Okay, was it sound?
Hello.
Yes, thank you.
Okay. Assalamu alaikum ji. I'm Dr. Farooq Mateen. Presently, working in Shifa for the last 25 years. I'm here, working as a director of neurophysiology services. Besides that, I'm also heading a college, which is Shifa College of Medical Technology. We have 4 years program, BS medical technology program in different fields, not only just neurophysiology, but other fields as well. And we have 2.5 year associate degree program as well. So we've been running this show for the last, probably 9 years. हमारे BS के 2 बैचेस निकल चुके हैं, BS मेडिकल टेक्नोलॉजी के, न्यूरोफिजियोलॉजी के, एंड ES प्रोग्राम के मेरे कोई 4 बैचेस या 5 बैचेस निकल चुके हैं, 4 से 5 बैचेस. मुझे हर साल जो है तकरीबन इस फील्ड में 11 से 12 बच्चे हमारे इस फील्ड से निकलते हैं. We have HEC recognized course. Recently हमारी कुछ लोगों से बात हो रही है, तो हम KPK में भी and बलूचिस्तान में भी हम we want to run the same kind of show with the same kind of curriculum. So हमारा curriculum जो है वो श्रीलंका में भी launch हुआ है in their technology programs. तो यस, डॉक्टर आरिफ एंड खैर मुस्तफा भाई से तो मेरी बहुत पुरानी एफिलिएशन है, फॉर द लास्ट 20 years or so. So हम जिस कैपेसिटी में भी, इफ यू वांट अस टू वर्क विद यू, कोलैबोरेट करें, कुछ करें, वी कैन. नया बैच हमारा अभी शुरू हो रहा है 21st से in both BS and AS programs. We don't have any diploma program yet, but I actually personally discourage diploma programs because जो quality of work आपको चाहिए होता है from them is not possible just to make them understand in a year's time. जैसे वो डॉक्टर आरिफ ने कहा कि हम शुरू करते हैं, we have 8 semesters, और इसमें सिर्फ न्यूरोफिजियोलॉजी नहीं होती, इसके अलावा उनके ओवरऑल ग्रूमिंग होती है बच्चों की, चाहे वो लीडरशिप प्रोग्राम हो, ऑर्गेनाइजेशनल बिहेवियर्स हो, प्रोग्राम हो, मतलब उसमें सारी चीज़ें हमने डाली हुई हैं. इट्स अ हेक्टिक प्रोग्राम, यस. प्रॉब्लम मेरे साथ ये आती है कि जैसे मुस्तफा भाई को भी यही होगा अंदाज़ा कि हमारे बच्चे निकलते हैं एज सून एज दे आर ग्रेजुएटेड, तो वो यहाँ ठहरते नहीं हैं. वो दुबई, अभी भी मेरे पिछले महीने 3 बच्चे जो मैं उनको हायर करने के मूड में था और वो चले गए. सो ये एक प्रॉब्लम हमें मिलती है, फेस करनी पड़ती है. बट यस, ठीक है, वो एक गुडविल डेवलप होती है, इनकी पर्सनल स्किल्स बेहतर होती हैं जहाँ कहीं भी जाएं. चित्राल से मेरे पास, हमजा से, दीर, अपर दीर, लोअर दीर, सब जगह से मेरे पास बच्चे हैं, अभी भी हैं. सो अब ये है कि इनको किस तरह वापस जाने के लिए इंकरेज किया जाए और वो किया जाए, तो वो बिकॉज ऑब्वियसली आपकी सैलरीज उनके साथ मैच नहीं करती जो दुबई या सऊदी अरबिया को दे रहा होता है. सो एनीवे, इन जो भी फ्यूचर में आपके लिए प्लान्स हो तो आई कैन वर्क विद देम, कोई इशू नहीं है.
Thank you, Dr. Mateen.
Thank you.
Dr. Okay.
Dr. Jangiri, we'd like to request you to start your talk.
अच्छा, चलो, thank you. So मेरी talk जो है थोड़ी सी longer है, मगर I will try to just skip through. Okay, can you screen my screen?
Yes.
Okay.
You can see your screen.
Sorry. Let's go screen. One second. To share again. To share again. Okay. So just giving my background, a very quick background. I'm currently president of American Society of Neurophysiological Monitoring. I'm also president of Global Innovation, and I'm working as a vice president of clinical affairs at Access Neuro Monitoring in Richardson. We provide intraoperative monitoring services, and I have a teaching position as an adjunct professor at Labray College in Milton. They have online IOM program, so I teach there for the last 5 years. I'm also a lecturer in University of Texas at the Neuroscience Department of Neuroscience, and I teach intraoperative neuromonitoring courses there. So I'm also a diplomat, American Board of Neuromonitoring. So that's a diplomat certification. I also have a fellowship from American Society of Neurophysiological Monitoring, and also another fellowship for American Neurodiagnostic Society. I've been board member for American American Society of Neuromonitoring for the last 5 years. And I'm also assist editor for a neurodiagnostic journal, which is so I'm a graduate of Heber Medical College, class of 1991. So I did my MBBS from KMC in 91. After that, I did my house jobs in general surgery and radiology, and I moved to US. In US, so I did my post-graduation in biomedical engineering from Case Western with the research in EEG, machine design, 3D imaging, and computer software programming. After that, I found out about just by luck electrophysiology. I used to teach at School of Medicine and School of Dentistry and Ohio College of Podiatric Medicine there. So I found about electrophysiology, and so that was some interesting field. And so I moved to Michigan, Detroit, Michigan, and started my training in Detroit, Michigan. And then I moved to Philadelphia, Thomas Jefferson, and Baltimore, and then Seattle. And I also lived in Saudi Arabia. So I moved to Saudi Arabia in 2011. I was there for like 6 years, started program and developed the program, and then moved to Qatar as a senior consultant in neurosurgery. And now for the last 3 years, I'm back in Dallas. So that was just about me. So what is intraoperative neuromonitoring? So I'm going to briefly, we say IOM. So the term we use IONM. IONM is a continuous monitoring of patient nervous system, including brain, brainstem, spinal cord, and nerves when it is at risk during high-risk surgeries. The purpose of IOM is to protect the nervous system. So even it's a neurophysiological test, it's a neurological test, and we are monitoring about the brain, brainstem, and spinal cord or peripheral nerve, but we can get the information indirectly because if there's a blood flow, if you're monitoring the blood flow, so if it's a cardiac case, so if you're doing cardiac surgery, and you put the clamp on, it will cause ischemia to the spinal cord. So that's going to stop the function of spinal cord. And if it stay there for a longer time, patient may wake up with paraplegia. So you can indirectly, same as carotid endarterectomy, carotid surgeries are vascular surgeries or aneurysm. So if you block the vessel for clamp the carotid artery, you can lose the blood flow if the patient does not have a good collateral circulation and cause ischemia. So that will give you indirect indirect information about the structure. So if we are not doing intraoperative monitoring, we have to wait until the end of surgery for patient to wake up for neurological exam. So if any patient who go for any type of surgery, so you cannot tell the patient has all the function intact. So you have to wait. The surgery is over, patient is extubated and moved, and then you talk to the patient and start the examination. If patient cannot move after the surgery, if it's a spine surgery, a brain stem, or patient cannot feel any sensation, stereognosis, proprioception, all the somatosensory, or cannot hear, if the patient has a brain surgery, a brain stem, the hearing loss, or visual loss, any pituitary tumor, or any surgery on the frontal lobe. Or it could be a memory surgery in the memory area. Patient doesn't remember anything. Patient cannot comprehend, cannot talk. Depending on Broca's areas, Wernicke's areas affected, that means it has a permanent damage, because the surgery can be 2 hours, 4 hours, 10 hours, 15 hours long, and a damage happen. Most commonly is a permanent damage, it's irreversible damage. We try to do another surgery, try to explore and see what's happening and try to fix it, but mostly it's irreversible. When we are doing intraoperative monitoring, we can monitor all these functions intraoperatively while patient is being operated. So if there's a surgery on the auditory nerve, we can monitor the auditory function. If the surgery is on spinal cord, we can monitor sensory and motor pathway while the surgeon is operating. Or if it's a surgery on thyroid gland, so recurrent laryngeal nerve is superior and recurrent laryngeal, they are at risk. So we can monitor those nerves and give a feedback to the surgeon. So most of the changes occur in few seconds to a few minutes. So we can give an immediate feedback. So if there's a change, we alert the surgeon, and surgeon knows what they have done in the last few minutes, so he can reverse the last few steps. It may be a pressure on the brain, it may be just a pressure on the spinal cord, a retractor, or it may not have nothing to do with the surgery. It may be the positioning. The patient, you are doing a surgery on spinal cord, but patient is lying in prone position for 6 hours, and patient wake up with ulnar neuropathy. Patient has severe pain in the hand for the rest of his life. And so that's indirectly, or it could be just a drop in mean arterial pressure. So the change in mean arterial pressure is not enough to cause any alert for anesthesia, but it's enough to cause ischemia to the spinal cord. So we can pick up that very immediately, and we can give the feedback to the surgeon. So all the surgeries with a high risk are the surgeries, high risk surgeries, so we can and technically, they're all any surgery is high risk surgery, so we cannot say that for a patient, if you're doing a 1-level discectomy, it's a still high risk surgery. So I'm going to. So I'll ask, if you are not talking, please mute yourself. Thank you. So for example, scoliosis case. So if the patient have a scoliosis and you're trying to straight that curve on the left side, and you want to make it a straight on the right side, you have to put a lot of screws and rods and maybe wires and hooks in the spinal cord. So correction, you may be able to straight the spinal cord and prevent any further curvature, but patient may wake up with a paraplegia. Patient may wake up with a foot drop on one side or both sides. Patient may have a bowel and bladder dysfunction. So all those functions are at risk. So when you're doing correction or derotation or translation, you can tell the surgeon where to stop.
I have recording and I can't even have anything coming in.
Same as spine trauma.
You need to mute them, please.
Oh no.
Sorry.
No. Mama, kamay is kamay.
Okay. Sorry. So spine trauma, brain tumors, any brain tumor, patient with a brain tumor. So if you want to go and take that big tumor out, the sensory function, the sensory area, the motor area, the language area are right there. So you can identify them and prevent those damages while the surgeon is operating on that area. So, and we can identify the sensory hand area, sensory brain, foot area, sensory face area. We can identify the motor area for the deltoid, bicep, forearm, hand, face, all with a very precise stimulation and recording. Same thing as something like this. This patient has a CPA tumor, acoustic neuroma, a huge acoustic neuroma. And if you want to take the tumor out, you have to sacrifice the hearing. But you don't want to, if you're using the interpretive monitoring, you don't want to sacrifice, because the facial nerve is at risk for damage. The patient has a facial nerve deficit post-operatively. Patient will have a face drop, drooling, Bell's palsy, problem in the lacrimation, chewing, blinking. So all those can be prevented. And the hearing, like just giving you an example, in US, for these type of acoustic neuroma or vestibular schwannoma, the chances of having a post-operative hearing deficit was about 40%, 38 to 40%. So in early 70s, they decided to start doing auditory evoked potential during these surgeries. So just doing auditory evoked potential, the rate of post-operative hearing loss or hearing deficit decreased from 40% to less than 1%. So so when we are doing surgery, so we are stimulating from one side and the signal is moving across the surgical side. So if the signal is okay, it is as good as before and after surgery, that means nothing is happening at that site. But if there's an injury, it can be it could be peripheral nerve, it could be spinal cord, it could be brain, it could be brainstem. If there's a damage to that pathway, to that structure, when the signal travels to that, it decreases in size. So signal size will be smaller than it was before. So the signal may increase in timing, it may arrive late, or it could be smaller in amplitude. So both of that will give us alert that something is going on. So if there's no change, there's no intervention needed. But if there's a change, then we need to have intervention. So when we are operating on the high-risk surgical procedures, we are looking for the post-operative deficit. So if there's no, or we are not using any intraoperative monitoring or have a poor IOM data, there's a change in IOM, patient can have a post-operative deficit. Patient may be paralyzed, maybe not able to walk. If they have a good IOM, patient will be able to walk and have all the function there. Same as other type of surgery, if the patient, the surgery is at the facial nerve or auditory nerve, patient may wake up with the facial paralysis or hearing deficit. If you are doing a good IOM, patient will have no changes and will be okay post-operatively. So the IONM or intraoperative monitoring helps in better patient outcomes by minimizing the risk related to the functional status of the nervous system during surgical procedures. If there's an IONM alert, we inform the surgeon immediately, and that can help to identify the cause and take immediate corrective action. Learning about the advantages is and the potential medical legal risk is the objective we are going to talk later. So when patient is going to have a surgery, the definition according to the term neurophysiological monitoring is defined by American Society of Neurophysiological Monitoring as any measure that is used to assess the functional integrity of the peripheral nervous system or central nervous system, either in the operating room, the intensive care unit, or any acute setting. So that's the definition of the. So what I do is, because neurophysiology, when you talk to any person and you talk to especially neurophysiologist, it's a very broad term and it can be applied to different type of application. So I usually subdivide into 4 different categories, which are more common. The number one is diagnostic or clinical. So we can call it diagnostic neurophysiological testing or clinical neurophysiology, which is the most common one and most of us familiar with. So neurophysiological monitoring can be used clinically for diagnosis of various disease, for epilepsy, multiple sclerosis, neuropathy, myopathy, hearing, visual deficit, vasospasm, like a TCD. So we use all these tests in a clinical setting to diagnose underlying condition. So that will be a diagnostic use or clinical use of neurophysiological test will be under diagnostic neurophysiology. The same neurophysiological test can be used for prognostic purpose. So the prognostic neurophysiology is used in the intensive care unit. So it's not only limited to clinical use or OR use, it can be used in ICU. And it is used for diagnostic and prognosis of various disease. So if you want to go and see how the patient is doing, you can use these tests. If the patient has status epilepticus or subclinical seizures, or you want to induce a patient in coma, patient has cerebral hemorrhage or cardiac myocardial infarction, and you want to induce coma, you can induce and use EEG and make sure the patient doesn't come up. Or patient has a brain death, we can go do this testing and confirm patient has brain death. And stroke and the other. So there are other multiple conditions where we can use in ICU and tell the patient is getting better or worse. The third one is a therapeutic. So there are some tests that can be used for therapeutic purpose for treatment, such as treatment of Parkinson's disease, spasticity, acute stroke, trigeminal neuralgia. So we have deep brain stimulation for treatment of Parkinson, essential tremor, dystonia, myoclonus, Tourette syndrome. So there's, and then for spasticity, patient with cerebral palsy, we can use these testing and we can make their life better. And also for stroke, so we have the patient is brought to the hospital in time. Patient, we can use focus ultrasound. It's a focus ultrasound is used for dissolving the stroke area. And also for trigeminal neuralgia, pain, like a spinal cord pain, leg pain, we can use cortical implant, spinal cord implant, and treat the pain. So the last but not the least, so we are going to talk today is intraoperative neurophysiology or surgical neurophysiology or IONM. So the intraoperative neurophysiology or IONM is used for preventing mechanical, ischemic, or heat-related injuries. So the purpose of doing the intraoperative IOM is not to diagnose any condition, not to treat the patient. Sometimes we use the treatment for spasticity and pain, but mostly we want to make sure that the patient is brought to the OR. Patient should not leave with any more deficit. So patient should have no sensory deficit, motor deficit, hearing, vision, memory loss while the patient is being operated. So that's the purpose of the intraoperative monitoring. So the growth of IOM in US market has is forecasted increased about 8.9% in last 4 years, and the next prediction is about 64% growth in orthopedic, and the overall growth is 10%. The incremental growth is about 955 million. So that's the demand is rising in US. The Europe is also catching up. Is getting, but in Asia and especially in Pakistan, it's like still need, and we want to bring it there. So the IM and industries, the IM services can be provided in neurosurgery, orthopedic surgery, vascular surgery, ENT surgery, cardiac surgery, interventional procedures, interventional neuroradiological procedures, coiling, the embolization, genitive urinary surgery where urinary bladder and all the different femoral nerve and genital femoral nerve is at risk, we can use that, and also for different type of general surgeries. So IM is used in many different countries and different models. In US, the IM is used in hospital-based service, in private contract companies, and subcontracted. So the services can be owned by the hospital or a private company. They have the service and they go to different hospitals and provide services, or they're subcontracted individual. they work as a freelance. So the two big models, they are in-house model we can provide. In KPK, one is in-house model. If the hospital is big hospital, they can create their in-house model. They can have their own neurophysiologist, IOM specialist, and technologists. They go into the operating room. They can see the patient before surgery. They can see the patient after surgery. So there's a big benefit for working for a hospital because you have access to the medical record post and you can see how the patient is doing. The other service we can also do is having a small group of neurophysiologists and technologists, and they go to different hospitals and they provide intraoperative monitoring services. So that will be more ideal model for hospital. They cannot afford a full-time staff of multiple people, and they don't need neuro monitoring every day. So that will be applied to that area. So we practiced this guidelines 2 years ago. So I'm also one of the co-author. So American Society of Neuromonitoring, we practice the guidelines for supervising physician. So the physician oversight, there are two different models. Again, the physician can be in the operating room and watching the signal while with the technologist from either that person, the physician can be in one operating room or can move from one OR to the other. If there are 2 surgeries or 3 surgeries, he or she can go into different surgeries and make sure everything is going on correctly. And if there's the changes in data, the technologist can call the physician and look at the data and talk to the surgeon and discuss the next step. The next step is the other model is the remote model. If you have a high-speed internet or Wi-Fi connection, the supervising physician can be in a remote location. It could be the office, the hospital, the home. They can watch. So if there's a surgery in Mardan or Karak or Dar es Mailhan and there's no physician there and there's a physician in different type of area, they want to have the surgeon, they want to have this service. This can be provided by a remote physician. So we can have a local technologist who work with that surgeon, but the physician can be in a remote location and then can provide services in multiple area in multiple cities. So this is the most common model in US because the lack of trained physicians who are certified in neuromonitoring. Giving you example, the technology, the CNM exam, they are about 4,000 certified so far since the start, and most of them, they are like many of them, they are not retired or they're working in management position. They're working, so there are about 2,000 technologists working, 2,000 plus technologists. They are certified technologists. They're working in US in about 8,000 hospitals. So there's a need. There's not even one technologist in one hospital in US. So there's a big demand for that. So if you are a trained technologist, there's a jobs guarantee, there's a bit security that you'll get a job because there's a demand. On American Board of Neurophysiology, which is for a board for physicians, there are 180 certified so far. Out of 185, there are about 133 active license. About 50 they are retired or their certification has expired. They did not renew. So there are only 133 American board neurophysiologists in the whole world. So half of the US state, they don't have even American Board of Neurophysiologists, but there are different certification from ACNS and other societies that has some IUM related certification, but the main certification in neuromonitoring is American Board of Neurophysiology. So there are multiple societies. So if you want to part of the, we can create our own society in Pakistan. Right now, there's no society of neurophysiology, so we can move to that. But right now we have national society, we have regional society, we have state society, and then we have international society. Right now, the international society is ISIN, International Society of Neurophysiological Monitoring. So the professional society in US, neurophysiology, and if you want to be part of members, is American Society of Neuromonitoring, American Neurodiagnosis Society, and American Clinical Neurophysiology Society. Those are the 3 societies focus on. So ASNM, or American Neurophysiology, which I'm currently president for this year, it is 100% intraoperative monitoring focused on, and the main purpose is education and research and training in the field of neuromonitoring. ASSET is a neurodiagnostic society from technologists and physicians, but it has a broad coverage. It has nerve conduction, polysomnography, electroencephalography, and IM. So IM is a part of that society, so it's not the main. So it covers different fields. The members are from different field of neurophysiology. American Clinical Neurophysiology is mostly on clinical neurophysiology side, but it has some intraoperative monitoring factors there. The International Society of Intraoperative Neurophysiology is an international society. It has members from all over the world, and they have meeting every year in a different country. So sometimes they go from one country to another country, so the certification exam, so if anyone want to be certified, because if you want to go training, there are two types of certification. One is by American Board of Registration of Electroencephalographic and Evoked Potential Technologies. So they have EEG, Evoked Potential, and IOM certification. The IOM certification, as Dr. Mustafa was saying, is known as CNIM, or Certification in Intraoperative Neurophysiological Monitoring. It's a 4-hour exam, written exam, a multiple choice question, 250 questions, and you can take online. It's on online test, and you can take it from Pakistan. So you don't have to travel. So that it can be taken from any country. You have to pay an extra fee for $100 more, and you can take the exam. So the requirement is you need to have 150 surgeries done, or you need to have at least bachelor degree in any field, and 150 surgeries done, different type of surgeries, and then you can apply for this exam and you can sit in the exam and pass the exam. American Board of Neurophysiological Monitoring, they offer DABNM, Diplomat American Board, and this examination started in 1999, and it is offered only for MD and PhD people. So if you have MD or PhD, so you need to have 350 surgeries, 300 surgeries done, but also work for 3 years. So CNM you can take anytime, but for physician you have to have at least 3 years wait time. So most of the time people take CNM after 1 year, and then they wait for 2 years and they take ABNM if you're MD or PhD. So you need to have 350 surgeries and 350 surgery 3 years, and then you take the exam. But this is a written and oral exam. Written exam can be taken from Pakistan or any country. So because again, it's a written exam center, online exam. So you can apply for the center, special center, and you can take the exam. The oral part is a once a year exam, and it's a special date. And so yeah, it's only in one of the city in US. So American Clinical Physiology is also, they have 2-part exam. So the first part one is general neurology. So for taking ABCNN exam, you have to have a neurology background, and you take the part 1 and then part 2. They are both written exam, MCQ. So but part 2 you can take in epilepsy or IUM or critical EEG, or so different type of EEG. So it's a 2-part exam, part 1 general neurology and part 2, and you can choose in intraoperative monitoring, and you can choose more than one. So if anyone who has not been to the operating room, so just going to quickly, so it's always the training we do, as we were discussing it earlier, because you need to have like some information about what we are doing in the operating room. So you have the daily task, the skill, the education, the certification, different understanding of different type of surgical procedure. What is the difference between spine procedure? What's the brain procedure? What is the difference between anterior cervical compared to posterior cervical, scoliosis versus lumbar case, thyroid versus brain tumor. So all these types of surgeries, so having this information is critical before you go to the OR, so you know what, so you can the reason we need to know is when you're doing intraoperative monitoring, we need to know the exact step the surgeon is going to take the next. What surgeon is doing now, what will be the next step? So what will be the critical area where there's a risk of changing? So if the patient is going to put opening the dura, it's not as risky as the surgeon placing a retractor on the brainstem, or patient cutting through the cerebral cortex. Same thing, or spine case. So if the patient has a trauma and has a fracture, you want to align, so any slight movement can cause rupture or ischemia to the spinal cord. So A technologist, when go to the operating room, they always go to the pre-op area, talk to the patient, take the history. History is very important. If the patient has pre-existing condition, patient has a hearing loss preoperatively or vision loss or has sensory or motor function loss, that's documented, that will affect our data. And then talk to the patient, get the consent, and then talk to the neurologist or neurophysiologist or surgeon what different tests we are going to use. So the test we use is depending on the type of surgery. So need to have a good communication skill, technical skills, analytical skills, because you need to interpret the data and inform. But it comes if you are motivated, it comes with the time. So it's important to understand the working in the operating room, how to work with the surgeon, the anesthesiologist, the nursing team, and if there's a remote physician. So the education, any degree in neuroscience, for a degree in applied sciences or neurophysiology, with a bachelor or master, you can work as a technologist or for a supervising physician, you need to have a MD or PhD. But the training specialist neuromonitoring will come with our whatever our going to teach, because it's not given in any school right now. So because you need a basic instrumentation, electronics, what are the filters, what are the stimulation, what is recording setup, anatomy, physiology, and knowledge about the anesthesia, knowledge about the surgery. So all these information, these are a part of the training. So the different examination beside the BLS, it's a CPR. We have EEG, registered evoke potential technologist, registered nerve conduction, CNIM, and DIBNM. So the last two, CNIM and DIBNM, are more focused for intraoperative monitoring. So how this works? So before the surgery starts, the technologist and the physician, they talk to the patient, get the history, and set up the stimulation and the recording depending on the type of surgery. Once the patient is intubated, patient go to sleep, we start stimulating and recording and get a baseline data. So we need a baseline for all the tests we are doing, and and then we see that baseline may be good, may be bad, depending on how the patient has a hearing loss. So the auditory test maybe have a poor responses. This patient has a weakness. Patient has a 3/4 power in the legs instead of 5 after 5. Your motor evoked potential responses will be poor in the beginning. But once we have a baseline, then those are our baseline. And we want to take the baseline after patient is in anesthesia, because when we stimulate, it's painful. We don't want the patient to feel the pain. Plus, the anesthesia affect the signal. Anesthesia block the synapses. It affect the signal. So we don't want to have changes in our signal. But once we take the baseline after the anesthesia, the signal, if there's a signal change, then we can identify what is the reason of change and inform the surgeon. And if there's a change, we can inform the surgeon, and surgeon, if the surgeon listen to that, then they do the reverse the procedure and can prevent that. So we have different types of electrode, information about the operating room, where's the patient head, where's the anesthesia machine. When the surgeon anesthesia is giving the anesthesia, patient is intubated, wait for that. And then after that, we put the electrode and place our equipment at the right speed, so there's nobody tripping on the wires, and the wires electrode doesn't come out. Making sure what is the instrumentation, what are the tools the surgeon is going to use. We don't, it's sometimes green or blue, so we don't go close to that. So you have to stay at least 2 feet from that. We always facing toward that. When we are moving in the OR, never turn back. Even you think you are too far, you always stay away from that. So the purpose of neuromonitoring is to improve the patient care. We want to reduce the patient neurological deficit post-operatively. We want to improve the surgical morbidity and mortality rate. We want to reduce the hospital stay, less burden on the hospital and medical costs associated with that. We want to reduce any insurance burden if there's insurance involved. We want to reduce the burden on families and doctors because of the post-operative deficit. The patient have post-operative deficit, patient receives much burden and more surgeries, more clinical testing. So the importance of the IOM neuros type of surgical can benefit from thus utilizing IOM. They are classified as surgical specialty in orthopedic, neurosurgery, cardiac, ENT, The efficacy of IM has been studied in spine surgery where significant benefit occurs, including reduction in quadriplegia and death. So IM is now considered standard of care in this group and likely to remain for this service. So this is the quote from one of the paper, but it is getting standard of care in all different types of surgery right now. So three main benefits of the doing monitoring is increased safety of the surgical procedure. So if you're doing any surgeries, you have more safety, the patient will wake up with no deficit. Increased ability to accommodate more complex. So if you're in a hospital setting and you have a complex patient and you are afraid of touching that patient because patient may wake up with more deficit. So now if you have IUM services, that will be kind of your GPS. So if you have GPS, you are sure that you're not going to get lost. You're going to get on your destination. But at the same time, you want to make sure you don't have a very poor quality GPS or a bad data, because if you have poor GPS, you may be going to Peshawar and you end up in Karachi. So you're doing it going north, but GPS take you to south, or you're going in one direction and it take out to the other. So you take exit after 100 miles, and maybe it was after 10 miles. So the trust, that's why we need to have a good trained people in the operating room you can trust. So the somebody is a technologist in the room or a physician in the room that tells the surgeon, stop, there's something going wrong. The surgeon should have trust on that patient, on that person, that every time this person tells me, most of the time, 99% time, that person is correct. So if every time you tell them there's something wrong and not patient wake up fine, so we don't want to have false positive and false negative. False negative is we say, okay, nothing is wrong and patient wake up with deficit. False positive is if you tell nothing is something wrong and patient doesn't wake up with any deficit. So we don't want to have both of them because that will lose the trust of the surgeon. The third one is decreased risk of adverse surgical outcome. So those are the three main benefit. So modalities, I'm going to just want to give you an update about modalities. What is a modality? So this is the term we use all the time. So modality is a specific type of electrophysiological or neurophysiological test that used for testing specific neurological function pathway during different type of surgery. So all the different tests we use in the OR or clinical, they are known as modalities. For example, SSCP, which is somatosensory evoked potential, it is for protection of sensory pathway or ascending pathway. TCE-MEP is transcranial electrical motor evoked potential, that's for protecting the motor pathway or descending pathway. BAEP, brainstem auditory evoked potential, is to protect the auditory pathway. VEP, visual evoked potential, for visual pathway. EMG is for protecting the cranial nerves, either peripheral nerve or cranial nerves. There are two types of different tests. One is free running, spontaneous EMG, and one is stimulation or triggered EMG. EEG or electrocorticography, which is recording of the brain for brain ischemia directly from scalp or directly from cerebral cortex. If you're doing from scalp, we do EEG. If you put the electrode on the brain, we call it electrocorticography. TCD is another test. We use that for transcranial Doppler. It's most of you are familiar with using in clinical setting, but intraoperatively in carotid surgery and aneurysm surgery, we can use them to measure the blood flow of the arteries of the brain. DECS is another test, direct electrical cortical stimulation. We can stimulate the brain with the probe and electrode, and we can tell the surgeon this is the sensory area, this is the motor area, this is face, hand, arm, leg, tongue, whichever area. So we can identify and put the markers there. MER is micro electrode recording. Those is a micro electrode recording, and it's used for identifying nuclei in the brain for placing deep brain stimulator. So those are different tests. And I'm just going to go very quickly on all the some of those tests. Somatosensory evoked potential is the test as you see in this picture. So you put the electrode on the stimulation in this picture. On the right side, you can see you put electrode on the right malleolus on the ankle and stimulate posterior tibial nerve. You can stimulate the I'm not going into very detail, but you can stimulate the median nerve, ulnar nerve, radial nerve, posterior tibial nerve, femoral nerve, saphenous nerve, facial nerve, so we can stimulate and monitor the sensory pathway. And this is the posterior tibial nerve recording and median nerve. The upper left is the median nerve from the left hand and the right hand. And then we record from brachial plexus, brainstem, brain, and the lower left and right, they are from posterior tibial, recording from popliteal fossa, from the lumbar area, and from the brain area. So the name of the peak is are negative or positive NNP, and the number you see on the pictures is 20, 13, 45. They are how many millisecond it takes. So if N20 means a negative peak, it takes 20 millisecond. After stimulation median nerve, it take 20. P37 is a peak which takes 37 millisecond to reach the brain. So we're looking at these timing of throughout the speed, stimulate nonstop throughout the surgery, and we see if there's a change in and there's a change in timing or a decrease in the amplitude. Amplitude is the size. That means we alert the surgeon. So somatosensory signal, there are 5 different types of signals which we are monitoring. One is stereognosis. Stereognosis means the patient, you can hold an object and tell the shape and shape of the object is round, square. Weight discrimination. If you hold object, you can tell it's heavy or light. So proprioception. Proprioception is telling where the body part are in time and space. You're looking at the monitor right now, but you know where your foot is or your hand is without looking at. That's proprioception. 2-point discrimination, light touch. So those are 5 functions which are when we do somatosensory evoked potential, we are monitoring all of them. So if there's a change or loss of signal, patient is going to lose all those functions, which is very critical. Pain and temperature, they are different pathway. They are spinothalamic pathway. They are sensory are in dorsal column on the posterior part of the spinal cord. Spinothalamic, which is pain and temperature, is on the lateral spinal column. We do not monitor that, and we have not been monitoring that in the OR right now. The second test is transcranial motor evoked potential. Like there are hundreds of papers published on transcranial motor evoked potential. Transcranial motor evoked potential is you can do a motor evoked potential testing of the motor pathway by stimulating electrically or by stimulation magnetically. In the OR, we don't use magnetic stimulation because all the instrument will start flying in the OR. So we want to stimulate with electrical stimulation. So we stimulate with the brain, put electrode on the scab or direct on the brain, and the signal goes down. And we can record from the muscles, or we can record from direct from spinal cord. If you record from the spinal cord, it's known as epidural space. It's called epidural D wave or direct wave. Or you can record from the muscles, from the hand, leg, foot muscle in this picture, and we can tell the signals are okay. And if there's a change in the signal, that means either it decreases in size or it doesn't appear. That means something wrong. The other test is EMG. So EMG can be spontaneous. You put the electrode in the muscles and it runs continuously, and we know if there's in this picture you can see red and blue. So the red is the right side of the body, right quadriceps, tibialis, gastrocnemius, right foot, and anal sphincter muscles. So 5 muscles on the right side and the 5 muscles on the left side. So we're monitoring for the lumbar spine surgery. But you can see the difference between the responses on the right versus left. The right is very smooth, straight line running, but on the left side it is you can see those spikes or activity. Those are severe irritation of the nerve roots. So nerve or spinal cord is getting irritated due to different some reason. Heating, bovie, stretching, anything can cause that. So that is, so we can alert the surgeon, because if this is the activity without monitoring and it stay there for many minutes, so even for minutes, patient will wake up with a deficit. Patient will have pain or numbness or tingling post-operatively. So we can minimize those things. Triggered EMG is used for either stimulating the nerve directly or brain directly, or screws. So if you're doing screws placement in the spinal cord, in the spine, so you can see on the right side. So the screw should be in the bone, but if there's a breach, there's a break in the bone, it may not be very obvious on X-ray or C-arm, but it's big enough to cause current leakage. And then the we stimulate the screw and get a response. The response is at low current. If the response get a higher current, that means the response is not leaving the bone. So if on the left side there's a breach, so anyone can tell the breach. But micro breaches or the breaches which are not visible on the C-arm, that can be easily detected by triggered EMG. Another test we do is brainstem auditory evoked potential. So just giving you the names of the test, not giving you how to test and how to set up. And this is for preservation of hearing. So the hearing, when you stimulate the ear, on this side, you can see the right ear, and then you have one response. There are 7 peaks which are created on the pathway until the response go to the other side, and some on the same side from the brainstem and cortex. So we do this test for cochlear protection of the cochlea. We can monitor the cochlea. We can monitor the cranial nerve protection. So for nerve protection of cranial nerve during the surgery, so there's no damage to the nerve, and for brainstem protection, so there's no brainstem. So if there's a change or damage to any of these three, is going to affect your brainstem auditory evoked potential and hearing test. Another test is EEG or electroencephalography. It is continuous recording of brain activity from scap. So brain activity is a spontaneous activity. You can put electrode and we record and usual measurement of cortical perfusion. So it gives you information about how the flush and blood flow is, and also give a gross measure of depth of anesthesia. So it tells about the depth of anesthesia and the perfusion of the brain. If the patient starts seizing, we can also see that on the EEG. So it gives you a spikes before patient go into convulsions. Cranial nerves, we can monitor all the cranial nerves except for cranial number 1, olfactory nerve, because it's difficult to monitor while patient is under anesthesia. But all the other nerves, from optic nerve to hypoglossal nerve, all the 11 cranial nerves, 2 to 12, they can be monitored by different testing. So there are 12 pairs of the nerves. So the optic nerve and vestibulocochlear nerves are sensory nerves. So we monitor by stimulating visual stimulation and auditory stimulation and records. And the other nerves, they are motor nerves. So they can be monitored by EMG or motor evoked potential. So we can do corticobulbar MEP while surgeon is operating. So we can stimulate the brain, or the surgeon can stimulate the nerve. Or to identify the nerve. So the reason we do the cranial nerve stimulation testing is you can identify the nerve, which nerve is that, or if there's a tumor, there's a nerve behind this tumor or inside the tumor, and which nerve is that. And once you find the nerve, you can track the nerve. It's going to left, right, straight, medial, lateral. And then at the end of surgery, when you remove the brain tumor, you can tell if this tumor is, the nerve is still intact and the function of the nerve. So this is just like a picture of the patient, one of the patient setup. So you can monitor all the cranial nerves. So this patient has electrode around the eye. So we are monitoring the different, the eyes that supplied by cranial nerve 3, 4, and 6. So you can monitor the cranial nerve 3, 4, 6 by placing the electrode in lateral rectus, inferior rectus, and superior oblique muscle. So there are different tests, but there's not a single test which gives you the best benefit. So you cannot choose one of them. So because one is for sensory, one for motor, one for hearing, one for vision, EEG. But when we use all different tests at the same time, we give the maximum protection. So that's known as multi-modality. Multi means many, modalities, more tests. So multi-modality is the best approach. So depending where the surgery, if it's spine surgery, we do sensory evoked potential, motor evoked potential, and EMG. If it's a brainstem surgery, we do sensory evoked potential, motor evoked potential, auditory evoked potential, and EMG. And if it's brain surgery, then we do EEG. And if it's optic nerve or pituitary gland, if it's a thyroid, we do EMG and motor evoked potential. If we do parotid gland, we do EMG, triggered EMG, and motor evoked potential. So depending on the strategy, so multimodality is the best approach. So you can do SSCP, EMG, ABR. So you can choose whichever is needed. So surgical application, so there are different types of surgery we can apply. Neurosurgery, brain tumors, brainstem tumor, aneurysm, microvascular decompression, spinal cord tumor, peripheral nerve, cortical stimulator, spinal cord stimulator, Parkinson, dystonia, essential trauma, deep brain stimulation, all the deep brain stimulation. Cardiovascular surgery, cabbage, carotid endarterectomy, aortic aneurysm repairs. So all these surgeries that we can use neuromonitoring and has been documented to have good benefit. Orthopedic surgery, any spine surgery, cervical, thoracic, lumbar, sacral, peripheral joint surgeries, shoulder surgeries where radial nerve, musculocutaneous axillary is at risk, we can monitor all the nerves and minimize the damage. And it has like risk of those damage for 16-20%. Scoliosis cases, like hip cases, limb, tibial osteotomy, fibular osteotomy. We published a paper on the series of this patient. ENT surgery, parotid tumor, thyroid tumor, facial nerve tumor, cochlear implant where facial nerve is at risk, general surgery, nephrology, even OBGYN surgeries. We have been called by OBGYN and nephrology surgery because they are doing a hysterectomy, but patient wake up with in US, the published research says that patient hysterectomy has a postoperative urinary incontinence of up to 38, 40, 50, 40%. So it's very high risk of having a urinary incontinence for rest of your life. And you have to wear adult diaper for us. It's not, so you can monitor the bladder, sensory and motor function while they're being hysterectomy and different positioning. There's a paper published from University of Virginia. There was a in Da Vinci surgeries, patient 7% of patient going into gynecological procedure, they were waking with ulnar neuropathy because the way they were positioned, they woke up with the severe stretch of the brachial plexus. So prostate surgery has also, IOM is also being used in prostate surgery. It's not very common, but with the prostatectomy, there's a high risk of erectile dysfunction. And so that can be minimized more. So I think it's about, can be from 50 to 90%. And with the neuromounting, it's less than 25%. So different surgical procedure where we can do anterior neck surgery, posterior neck surgeries, all the instrumentation, spine fusion surgery, different type of spine fusions, pedicle screw stimulation, or any surgery where you're placing pedicle screw, want to test the screw before the patient wakes up to make sure the screw is in the right space and it's not breach the bone. Cranial nerve surgery, any surgery which is involved in cranial nerve function, so we can monitor facial nerve and other nerves in that sort of type. There are different types of surgeries, sitting position, brain, the brainstem tumor or brain tumor, and you want to have decompression or tumor resection, you can do in monitoring. Brain tumor surgeries, it's thyroid tumors, identifying the recurrent laryngeal nerve. We can put the tube has attached electrode, you can monitor from vocal cords, and we can monitor, give the feedback to the surgeon. We can identify the nerve. So real-time monitoring is when the surgeon, when the physician is not in the OR. If the technologist in the OR and the physician is online remotely, that will be our term for use for. So functional cortical mapping is another very benefit for neuromonitoring, vastly published and accepted. Mapping of the somatosensory cortex, we can map out the whole somatosensory cortex. We can map the motor cortex. We can map the language areas. We can map the Wernicke's area, Broca's area. There's a speech production area. And then we have area for verbs. We have area for nouns. We have area for adjectives. So we have different areas we can stimulate and talk to the patient. So in these surgeries, patient has to be awake, and we stimulate and record and talk to the patient, show the pictures, show them the words, ask them to complete the sentences. So different sentences, and we can do that. Epilepsy surgery. So if you want to take out the focus of epilepsy, many times there's no enhancement on MRI, so you cannot see on MRI. But if you do electrocardiography and stimulation, and we can identify neurophysiologically the location of the focal of the seizure and remove that. Microelectrode recording for deep brain stimulation is also another. So this is one of the surgery where the brain is exposed. You can see the brain is exposed, the dura is moved. And before doing anything, we put this grid. So this is a strip which has 8 contacts and this one 6 contacts. It can come in 4 contacts, 6 contacts, up to 64 contacts in one. So we can put that, and on the right side, we can see the signals. So these signals, it tells us if it is a precentral area, the response in precentral is down and up, the postcentral is up and down. So you can see the change. The central circuits in this picture is between grid number, response number 1 and 2. So 3 and 4, the bottom one, they are getting smaller because you're getting far from the hand area. So this is just for the mapping of the hand median nerve area. So language mapping, the setup we do, we talk to the patient pre-op, we do a full examination before the day of surgery. On the day of surgery, we do pre-op language and look for the deficit. A patient has a deficit and no deficit. And then patient in the OR, we do sensory mapping, cortical sensory mapping, cortical motor mapping, and language mapping. Epidural recording is another. D-wave is epidural tumor or any other intramedullary tumors, you can put a grid or a very small electrode above the tumor and below the tumor and record directly from that area. We published this paper in 2012 for monitoring in fourth ventricle. So if you have fourth ventricle tumor, all the nuclei, brainstem nuclei are there, cranial number 6, 4, 5, 7, 8, 9, 10, 11. So you can stimulate and record from all those nuclei and map. And before, when you're taking the tumor out of very small floor of the fourth ventricle, we can identify that and minimize the deficit. Dorsal root azotomy is kind of therapeutic, kind of both, but that's one of the very best application. So patient with cerebral palsy, they go for Botox and braces and all these surgeries, but they still have spasticity. So in order to reduce the spasticity, what we do is dorsal root azotomy. So we want to decrease the sensory input, which is causing the muscle contraction. So if there's no neuromonitoring, what the surgeon is going to do is they're going to go open and the lumbar quad equina, and from L2 to S1, they're going to cut all the nerve sensory root in 50%, 30 to 50%. But that's non-selective rhizotomy. You're just randomly selecting. So you might be cutting the good rootlets and leaving the bad rootlets. You have no idea. But with the neuromonitoring, with intraoperative monitoring, we open those roots. We open every single root into rootlets. So here L1, L2, L3, L4, S1. So we split into 2, 3, 4 branches, and then we stimulate every root separately, like see in the picture, and we look for the poor responses, and I tell the surgeon which one is the bad rootlet and cut only the bad rootlet and leave the good one. So you don't want to cut all the rootlets, but so if you do a selective and then have rehabilitation post-operatively, patient can have very good post-operative life, and patient can be able to walk and can move. Lipoma surgery, patient with lipoma, so removing of the tethered cord. So it's very difficult to identify the nerve root, so you're taking that lipoma out. So we stimulate, so this is a trigger EMG, so you're stimulating, you can see the responses in blue and red. And on the left side, you can see this is spontaneous EMG while the surgeon being operating. So I have connected my camera to the microscope so I can see my data and my electrophysiological data and also the microscope input, so I can communicate with the surgeon. So you can see there's a stretch on the nerve while the surgeon is manipulating to that lipoma, and that's causing this activity. So this is a new electrode. So I have published 2 papers. Those are the only 2 papers published. One is trigger EMG from the bladder and motor evoked potential from the bladder. If anyone want to have any paper on any of these topics, just let me know and I'll email. So this is a electrode, which is, you can see in the middle picture, it is a thin film which is attached to the Foley catheter, and when to the balloon. So when you insert, and you can get recording from the external urinary sphincter, and we can record EMG and spontaneous trigger EMG and motor evoked potential successfully from bladder electrode. Until now, we were doing only for monitoring the pudendal nerve, because pudendal nerve is very, very important at risk. It controls the bowel and bladder function in these quad equina spine cases of the lumbar area. If there's damage, patient will have no bowel and no bladder function. Patient will have incontinence and cannot control the bowel. So we do, the anal sphincter muscle is very easy. We have been monitoring for 20 years. Can you please mute whoever? Someone has a microphone on. So we can put electrode in the anal sphincter and monitor pudendal nerve, but the pudendal nerve branch is going to the bladder is a different nerve. Until now, we couldn't monitor that intraoperatively, but now we have this special catheter, and we can place that and monitor and minimize post-operative neurogenic bladder. Intramedullary tumors. So this is one of the cases we did and published for a kyphoscoliosis. You can see the patient. I was putting electrode on the head and anesthesiologist sitting. So this patient has a very bad curvature. It has kyphosis and scoliosis. And it came for surgery a couple of times. I'm going to, I don't know who's. So we operated in this patient, and to make a correction, the other surgery we can use is ENT surgeries. So ENT surgeries during high-risk surgical procedure, monitoring of facial nerve, vagus nerve is utilized for protection of the patient motor function. So parotid tumor, we can, if you're doing a parotid tumor, the parotid gland is, if you have done, remember the dissection, the parotid is a very tough, and all the 5 branches, temporal, zygomatic, buccal, mandibular, cervical, they go to parotid and then supply the face for the expression. But and if that's damaged during the surgery, that patient will be have facial paralysis. So what we can do, we can stimulate on the skin, we can mark all the branches before even start the surgery, and then we can do motor evoke protection and continuous trigger EMG while you are operating or you are taking the tumor out, and have no deficit or minimum deficit post-operatively. Vagus nerve monitoring, again for thyroid surgery, we can put the electrode in the vocal cord. We have superior laryngeal nerve and recurrent laryngeal nerve. Superior laryngeal nerve can be monitored by placing the electrode in cricothyroid muscle. Recurrent electrode monitoring, RLN, is monitored by placing electrode on the vocal cord. And because this, otherwise the patient can have hoarseness, or patient can have total loss of voice post-operatively. So these are different endotracheal tubes. So some of the tubes, they come with a pre-embedded electrode. They are already attached to that, and you can just plug and can monitor the left and right nerves, the recurrent nerves. Or if this come also on a sticker form on the left, so you can a sticker which can be applied on any in 2 size adult and pediatrics. So you can, there's a much cheaper prices, less than, I think more than 80% less price. So you can place that sticker on any endotracheal tube, and you can monitor from these patients. So when we're talking about thyroid, say, okay, why we monitor? Because you can identify the thyroid very easily, but in some cases, so it could be a very simple thyroid cases, or it could be very bad goiter, and it might not be able to find where is the thyroid nerve, recurrent laryngeal nerve or superior laryngeal nerve. So these, all the surgeries we did, the surgeon is holding, and you can see the oro in the middle. The surgeon is pointing to the recurrent laryngeal nerve. So, and when you're looking at the atlas, so everything looks very nice. Yeah, blue veins, red arteries, and white, yellow nerves. But when you're under the microscope or in the OR, everything is red and bloody. So it's very hard to identify something. Hip surgeries, so all the hip surgeries, so also sciatic neuropathy is rare, but typical complication of hip replacement surgery in literature, the frequency of occurrence is about 0.17 to 7.6%. So sciatic nerve damage, even femoral nerve is at risk, saphenous nerve is at risk, pudendal nerve is at risk. So all these nerves can be monitored in these hip surgeries, in total joint replacement or acetabular or acetabular surgeries. The other application, again, brain application in the brain, carotid artery, aortic, those are the vascular. So in vascular surgery, we can have all these surgeries. We can do neuromonitoring and give the benefit. Just giving you example, like for brain surgeries, aneurysm, if arteriovascular malformation, microvascular degeneration, extracranial, intracranial bypass, you're doing bypass or tumor, we can do EEG, SSAP, motor evoke potential, direct cortical, all these tests. We can do that, and we can minimize, because there's a risk of ischemia due to retractor or temporary clipping, or ischemia due to permanent clipping, ischemia to decrease in MEP. So all these different factors that can cause that. So carotid surgeries, we are removing endarterectomy, you're taking the plaque out of the carotid artery, but we can do the EEG. So as soon as you have to block the carotid artery, common internal and external, to take the plaque out, it take 10-15% patient, they don't have good collateral circulation. So EEG, it takes 15 seconds, 20 seconds, 65% of changes occur in the first 20 seconds. So as soon as you put ischemia, it takes 25%, 20 seconds to have changes 65%. 80% changes occur in first 60 seconds. So, and 99% 2 minutes. So you can tell the surgeon immediately the patient needs shunting to operate or not. If there's no collateral, you do shunting, but we can decrease those. Also aortic repairs, thoraco-abdominal So aorta surgeries, cabbage surgeries, the ischemia to the spine, chance of emboli, drop in mean pressure, vasospasm. So all this can be done by neuromonitoring. Interventional procedures for coiling, carotid stenting, spinal AVM embolization, we can do neuromonitoring in those two. So just a summary of all those surgeries where we can do neuromonitoring. So in summary, again, the same slide, we talk about the its application is not just for neurosurgery or spine surgery. It could be any time where the nervous system is at risk or any tissue is at risk where a nervous system can be monitored indirectly. That structure can be used for neuromonitoring. For the key factors, the IM provide consistent standard of care. It monitors neurostructure at risk during surgery. You can notify the surgeon immediately when the necessary to allow intervention, because post-operatively, if you find after surgery is too late, reduce the chance of patient deficit during surgery. Certification and continuing education of highly trained technical staff is required to do that. Credentialing of supervising physician also needed. So if we can do joint accreditation, joint commission accreditation, that's great. And a 24/7 coverage can be also provided for trauma and emergency cases. So in a survey of 173 spine surgeons in the US, 86% indicated that use IM for 51,000 cases, and experience operating teams of 300 cases monitor, more than 300 who have monitored, had less than half of rate of neurological deficit from surgery than those with the least experience, 100 cases monitored. So this is what Dr. Newer published this paper in 1996 about a survey on this one. So the team, even with the neuromonitoring, the team which has more than 300 cases monitored versus have less than 100 cases monitored, the rate of deficit was much different. So experience counts a lot. So another one, in this paper was analysis of more than 100 routine, non-trauma, non-tumor spine surgeries, found that cases where IM was used were significantly less likely to have neurological complication and hospital mortality rate. So Dr. Jack Cartouche, who's practicing ENT surgeon in Michigan, and also one of the founding member of American Society of Neuromonitoring. I like his quote. He said, "Poor monitoring is more dangerous to patient safety than no monitoring at all. That's why we provide superior monitoring." So if you have poor monitoring, you're going to get more false positive, false negative, and you will lose the trust on neuromonitoring, or you will have a bad outcome. So it's better to provide the best. So in summary, the benefit of application IM for various surgeries, clear understanding of methodologies, so there, and from hospital risk management purpose, because it's also decrease the hospital risk management, identification of post-operative deficit, and also, so there are multiple papers. So I'm just put there for references. With they are published about different type of deficit that can be prevented in different type of surgical procedures. So I'll put this recording online. You can watch that if you want to watch. So we did this study published in 2011 about 2,000 cases, and we found out different rate of post-operative deficit in which we were able to minimize the deficit. For peripheral nerve surgery, for axial and lateral genital nerve, for brain tumor surgeries, vertebral column resection with a patient with Ehlers-Danlos syndrome, patient with EDS, they have very fragile vascular structure. So even you're not doing anything, patient can bleed and get paralyzed or can get deficit. Scoliosis, split cord surgery. So there are many procedures where we have published, and there are different literature available, and the rate of risk can be from less than 1% to more than 50% in different type of surgery in very well experienced and surgical centers in US. So this is another paper we published on our data in 3 years ago on 6,000 patients, 5,800 patients, and we found that there was less than almost 2% risk, or 3.2% risk of positioning changes. So just the changes which occur due to positioning of the patient and nothing to do with the surgical procedure. There are a special electrode, longer electrode, so published a paper on electrode, so that we're better for recording. So in essence, in summary, it's a teamwork where we have a neurophysiologist, we have technologists, we have anesthesiologist and surgeon. They work together, including the nursing. And one person cannot do everything, because if you put a very experienced um, neurophysiologist or technologist in the operating room and anesthesia does not cooperate, you will not get a signal, because they will abolish all the signals of anesthesia. Or if you have very good anesthesia and have good technologists or physician, but if you change it and the surgeon doesn't listen to the, if you alert the surgeon and the surgeon doesn't respond, then that will be not helpful, because the surgeon, so, and that develops over the period of time with the trust and everything, but that's a teamwork, and everyone has to be on the uh, same page to help each other. So I'm going to stop sharing my screen, and so this was just try to give like a 50,000 feet overview of neuromonitoring without trying to bore everyone, because you're not familiar with the most of terminology. So I don't want to, but also wanted to give you some idea about different type of techniques that are available, and these techniques are available for different type of surgeries where we can help. So we are open for questions. So if you have any questions now, we have some time. So if you anyone has any question. Dr. Temur?
Team.
Yeah.
We can take questions and answers. So we can, attendees, please, you can type your questions in the chat box, and also you can unmute yourself. We have Dr. Faisal Jangiri, and we have other distinguished panelists who have abundant experience from Pakistan, surgeons, and we'll be glad to take your questions right now. I think we have a question from Dr. Mustafa Khan. Do you suggest to do a baseline study first before starting OR?
There's a question, sorry.
Yes. Do you suggest a baseline study
Yes.
before?
Okay. So the baseline study is, if you have access, if you're working in the hospital and the patient is in a hospital, then it is easy to do a study in clinical, but that can be done only for sensory and auditory and visual evoked potential. Motor evoked potential you stimulate with the high voltage, so it's not possible. But if you don't have that data, that's still okay. We typically do the baseline after the patient is intubated. So because the anesthesia, whatever you have, if you have very good signals in the patient, but anesthesia will affect your signals, so that's not going to help us. So we typically wait for the anesthesia to give the anesthesia and intubate the patient, and then we take the baseline before we start the surgery.
Dr. Jangiri, we have a question from Dr. Farooq Mateen about the vendors and companies that would cater these services in Pakistan. Do you have experience? Any local physicians have any experience?
This is for me or Dr. Arif?
Anyone, Dr. Arif or?
In Pakistan, we have the Medtronic system, which is available to us. They will be offering you the machine and the disposable. for you, but they're not providing the services. They don't have very effective backup in Pakistan as well. And they don't have any training facilities for you. So everything is on your own. I don't know, Talha might know many other companies which might be available, but it's the only one I know.
Dr. Talha?
We are using Excel Tech. Dr. Arif is probably using Metronics. We have a Metronics system also. All of them have their vendors or people who are suppliers in Pakistan. But as he is, Dr. Arif has mentioned that the backup is not good, and they are probably not training us also. So when we from the government side, whenever we will put something in tender, there were many people will come up with many types of machines, but then we have to consult either Dr. Jahangiri or somebody else in Pakistan. If you want to consult us, we will happy to guide you that you should get a better system to work on with. So don't just get a system which is cheap in the market. Metronics is probably the better choice available in Pakistan at present.
Yeah, the three best options we have is Medtronic, Cadwell, and Excel Tech. So the other Nihon, Gordon, and the other machines, they are also have IM system, but the main market in US is Cadwell, but I don't know how good is their services. Medtronic has very good service in Pakistan, so Medtronic has very good system, especially the new system. Excel Tech has a good system. Natus has a good system as well. So all these systems, so the basic training is the same. Once you know like how to do the programming or setup, we are trained, you can work on any system. Innomed is a German machine, like which also has so even like what I learned from when I was in Saudi Arabia and Qatar was it's not the best system because sometimes you are trying to get the best system, but you don't have a good support in that market. So if you don't have a good repair or customer service, even you have a very good service, it will be very you will be in trouble. So if you have like a not the best computer, but the second or third best choice, but if you have a good customer support from the local vendors and the engineers in that company, that might be the better options instead of having a good machine and no support. Because if you have something break down and you need to get repaired, that you don't want to send them to US for and get back after months or Japan or anywhere. So
wonderful. If you don't have any more comments on this, we can certainly take some more questions. There are question from Dr. Mateen, Farooq Mateen, that do we use any special interfacing devices to connect the microscope and our intraoperative machines, especially when we want to use the remote access? And do we have our own VPN service?
So, okay, so those are two questions. So we need, so when you're connecting with the microscope, so you need just like a regular cable, and depending on the microscope, because some of the computers, they give you options of the video input. So if you don't have, you can buy any video capture device from the market and use in USB port. And if you have HDMI or any the connection, so all the different microscope have different connections. Sometimes they may come with a HDMI or mostly SVDO or SVDO output. So you have to like look at that and just need the capture, and you can just take, and they're video out, so you just use the video out and video capture device on your computer, and you can look at the video at that time. For the remote access, we need to have like an internet connection. If the operating room have Ethernet connection, that's the best option because Ethernet is the fastest. But if you don't have Ethernet connection, then you can use a 4G or 5G network, even 4G will be. So anything above 3G will help you in the remote monitoring. So you need to have a Wi-Fi connection in the OR all the time.
Any other questions from Dr. Talha has a question, I think he is.
So I just want to comment on this remote access while we are working in Pakistan, because the internet is something sometimes not working well, as far as connection of microscopes and other things is concerned, we don't have a concept of smart hospitals as far as I know at present. We may have the same in future. So the better option in Pakistan at present is that we should have a person who has good knowledge about neuromonitoring sitting in the theater, because when we are requiring a decision or a quick response, we need it there and then, and we cannot wait for that response. Thanks.
So that will differ. So it depend on the hospital to hospital. So in some hospital you may not have any internet connection, so you even have a good 4G or 3G device, it's not going to work. But if you have VPN connection, like somebody mentioned that, I think Dr. Mateen, they have the VPN service, so you can have their own Ethernet VPN connection, then you're one of the lucky one. If you don't have, then if you have access to the Wi-Fi internet, then if not, then if you don't have any in Wi-Fi, then you are not possible to do a remote monitoring. So you need to have a physician available nearby or in the operating room. So if anyone isn't so even you're not in Peshawar, like you're in Karachi or Lahore, Islamabad. So if you are interested, so we will be happy to be making a partnership and open to all the suggestions with all your experience. So we want to create this program, and we can start with a small program and we can start, as Dr. Arif said, we can have 2 programs. We can have like a master program and we can have a diploma program, because if you want to have 2-year program, then we have to wait for 2 years to people to graduate and then go to the OR. So that may be very long. So we can use the same people into diploma, and once they finish diploma, we can if they are have a higher degree, we can admit them to master program and continue while they are capable of working on the simple cases, and then train them for more advanced brain tumors or other more complex cases. So hopefully we will like to, whoever is in this call, so you can spread the knowledge. So the main purpose is to tell your colleagues and friends and professors, students about neuromonitoring, and get involved. And if you cannot, or you don't want to get involved, whoever is involved, refer to us, and we have created this task force initiative with the help of KMC AANA, and hopefully we are going to create some movement in that. So we are going to initiate an online short workshops, then go to the full program, and then hopefully we do some visit in different any hospital which is interested. We can come to Pakistan, we can do live cases, and if we have identified the people who are interested in learning, we can show them and give some initial training. And then we do continuously, even from US. If somebody is there, we can do remote monitoring. I can do there from here, and we can help them and train while you are in the operating room.
There's a comment from Dr. Farooq Mateen about getting HAC permission to get NOC. Any comments from Professor Arif?
Yes, I think that's correct. But as I said, there are certain guidelines. You can have a certificate program, which is a 6 months program. Anything less than 6 months is called a certificate program. Then you can have a diploma course, which is like a 1-year course. And then you can have a degree course, which is 2 years or more than that. So these are the general guidelines, and then you have to develop a curriculum for any of these programs. They have to go to the academic council of the university. They have to be cleared there, and then you're allowed to start the program.
Dr. Jangir, would you like to share your email or contact information for all the participants, or
yes,
they want to reach out to you? And probably we may have to do a conference call at some point whenever Dr. Professor Arif is available, and we can come up with the roadmap and get going with the initial steps for making the curriculum and approval and the whole, with all the guidance from the Professor Arif and all the faculties.
Faisal, I will send you the curriculum of one of our courses, and you can develop your curriculum based on that guidelines. What is your initial thought? You want to start a course, a BS course, or what sort of course you want to start?
So I think I will work on all three options simultaneously, because every program will be built on that. So I just wrote down, so you have certificate for 6 months and diploma for 1 year and degree program. So I'll prefer to start all three at the same time, because it's going to take a longer time. So if you do like diploma and then we go certificate, then diploma, we'll be looking for very long. So if you have if you can send me information of all three programs, I can start with all three simultaneously, and then we will submit the application one by one. Because if we have a paperwork and we start the certificate and we apply for degree, we have a basis for approval. So we can say we started this program and this is a model, and we are expanding this model for a degree program. And so that I think the chances of approval will be much higher than just going for direct degree program with no background, no experience in that current market. And I'm also thinking of launching a specific website for our initiative. So we will we put information for everyone who is involved. We can create a blog, and all of you, I just posted my email, faisal.jahangiri@gmail.com. And if you want to reach out to Dr. Timur or Professor Arif, so I think we can share their email if you're in local market. So I'm planning to, like, we should create like a website. I can work on that and have the current information, what we are doing every month, every day, and research and what we are doing. And people who want to involve, they can post their comments and communicate with each other. Because we want to keep this moving. We don't want to have this one thing and then one-time thing. And anyone who can think that can help us, please join us. And please volunteer, contact us, and we'll be here. Yes, Dr. Mateen, you want to say something?
Yes, Assalamu alaikum. I think इस regard में मैं ये कहना चाह रहा था कि to start with a diploma or 3 months or 6 months certification course only for the newcomers or beginners would be very difficult. Probably those who already have an idea, those who already have done their associate degree programs, like 2 years program in neurophysiology, would be more appropriate to offer them for this kind of which has a bit intense theory and practicals. To start with, मेरे ख्याल में 2 years would be much appropriate. और ये हो सकता है कि आप लोग ऐसे programs डिप्लोमा, जैसे मेरे पास जो BS program है उसमें 2 electives होते हैं. What we offer them is sleep studies. Now elective तो उसका नाम इसलिए दिया गया है कि हमने सोचा था कि intraoperative भी रखेंगे और ये रखेंगे तो a student could have anyone, लेकिन अब चूंकि नहीं है and we just have the sleep studies. और उसके साथ हम जो लॉन्ग टर्म वीडियो मॉनिटरिंग हम उनको इन 2 पे ऑफर करते हैं. सो वी कैन ऑफर द थर्ड वन एज एन इंट्रा ऑपरेटिव मॉनिटरिंग एज वेल. They have to spend 6 months. Yes, they do, because one semester is 6 months. According to the HEC guidelines, it's like one semester is 18 weeks semester. तो ये तमाम चीज़ें फिर हमें कोर्स को डिज़ाइन करने के लिए, उसके करिकुलम को डेवलप करने के लिए इम्पोर्टेंट होती हैं. बिकॉज उन 18 वीक्स में 2 हफ्ते उसके वो होते हैं जो उसके एग्ज़ाम के होते हैं. अगर हम किसी ऑलरेडी प्रोग्राम में उसको बज इन कर रहे हैं, लेकिन अगर ऐसा नहीं है तो फिर हमें कोई ऐसा कोर्स जो आप कह रहे हैं वो दैट वुड बी मोर अप्रोप्रिएट for people who already have a knowledge of neurophysiology, which is I think so. I think so. I may be wrong, but मेरा ख्याल है तो मुश्किल होगा किसी ऐसे के लिए बिल्कुल ही आप इंट्राऑपरेटिव में, बिकॉज evoke potentials, हमारे भी कोर्सेज में evoke potentials जो है is in the final semester, last semester में होता है. फर्स्ट 2 सेमेस्टर्स जो हैं वो ईजी पे होते हैं, एडल्ट एंड पीडियाट्रिक, फिर उसके बाद नर्व कंडक्शन स्टडीज, उसमें वो काफ़ी टाइम लगाते हैं, एंड देन इवोक पोटेंशियल्स। तो ये चीज़ें मेरे ख्याल में
Thank you, Dr. Mateen. I agree with you mostly, क्योंकि लेकिन the difference ये है कि this will be only focused on intraoperative monitoring, so we are not going to talk about nerve conduction and other EEG. So intraoperative EEG. At the same time, हम जो कह रहे हैं कि we want to start all 3 program at the same time is same thing कि हो सकता है, हमें पता नहीं है कि मार्केट में कोई ऐसे लोग भी हैं जिनकी कोई एक्सपीरियंस है, न्यूरोफिजियोलॉजी का बैकग्राउंड है, या IOM कर रहे हैं, या किसी ऐसे हॉस्पिटल में है और वो डिफरेंट हॉस्पिटल पेशावर मूव होना चाह रहे हैं, और जिस हॉस्पिटल में रिक्वायरमेंट है, तो क्योंकि वो तो एडमिशन क्राइटेरिया होगा, फिर एडमिशन क्राइटेरिया के बाद उस डिग्री को पास करने के बाद वो क्या कर सकते हैं, दैट्स अ डिफरेंट थिंग। तो हैविंग अ डिप्लोमा फॉर 6 मंथ डजंट मीन दैट दे आर ट्रेन टू डू एनीथिंग, और उसके बाद खत्म करने वाले दे आर डूइंग इट। तो उनकी एंट्रेंस के लिए रिक्वायरमेंट होगी कि उनके एक्सपीरियंस क्या है, उसको हम करेंगे। तो उसमें हमें लोग चाहिए जो डिपेंडिंग उनका बैकग्राउंड क्या है, उनके है, और उस प्रोग्राम में कैसे करें। बहुत अच्छे बैकग्राउंड के साथ आ सकते हैं, मगर दे डोंट पास द होल, फिनिश ही नहीं कर सकेंगे। तो उसके क्योंकि वो उसको काफी होगा एजुकेशनल प्रोग्राम है, तो उसमें फिर डिपेंडिंग अगर उनका पहले से एक्सपीरियंस है, दे कैन गो टू द डिप्लोमा प्रोग्राम एंड दे गो फास्ट ट्रैक एंड देन कैन कम आउट और कैन स्टार्ट डूइंग दैट। जो है जो बिल्कुल जीरो से स्टार्ट कर रहे हैं और उनको कोई आइडिया नहीं है, then we can put them for 2-year degree program or master program. So wo jo hai, we are going to move forward with like depending on every candidate, how they're applying, what is the background and what can they do. So hum usme phir criteria banayenge what they can do after they finish the program. Just giving you an example in US. So US mein when we hire technologists in the for the operating room, they spend only 3 months in the training and they start doing solo simple spine surgeries. So 90 days is a typical 100 like full-time training. They are doing 40 hours a week, full-time training only in the operating, and that's not all operating room. So mostly the first 4 to 6 weeks you have is all lectures. After 4 to 6 weeks, they start going to the OR and they have some OR time lectures. And then after 2 months, they go to the operating room, and 4 to 5 weeks, they start working independently. But that doesn't mean they can do every single case. So that's a just simple case with simple lumbar cases where they can do EMG, SSB, or motor evoke potential. So they can do in 3 months. So that's a typical like US model of neuromonitoring. उसमें बहुत सारे हैं लोग जो हैं वो कॉलेज से आते हैं, मगर अभी कोई there's no college, there's only one like few colleges. So one college is University of Michigan. So they have 4 year of undergrad degree in kinesiology. So that has kinesiology degree, and so they have focus on neuromonitoring. So whoever is doing that bachelor in science there, they graduate with neuromonitoring, and within 4 months, like on the net, they have done like hundreds of cases and they already passed CNM before they graduate. दूसरा certified program, the second library college है, which I teach in Boston, is वो जो है is online program, only online. Virtual, it's a hybrid mode, but mostly online. तो उसमें that's a 9 month, a 7 to 9 month program. It's only 2 semesters. With उसमें 7 months में they go through 2 semesters, and at the end they go to clinical training and lectures. So first semester is all training, and then they go to lectures, and then the second semester in lectures, and they are independent working on clinical setting. So and then Boston, Canada में है, मिशनर कॉलेज ने है 2 year master program है, मगर most of the है जो full time intraoperative focus training जो है 3 months जो है we can do like minimum cases. So after 6 months you can have very good trained technologists, and if you want to have more experience, then you get more and more. So while you can start using those people in the UR and keep doing training them. So even they are in a master program or a bachelor program, if you we can start a 2-year program, they can go, so we can create the first 6 months is their diploma. So if they pass the 6 months, they get the diploma, they go to the OR and they start working solo, because they have to take this exam, CNM, to 150 surgeries. agar they stay in the school for 2 years and then after 2 years they go for another 1 year to take exam, it will be 3 years before they will be able to certified. Magar this way they will be available and they will be able to do on they can continue on their degree program at the same time. Magar ye the future we can think about that, and then it all depend upon the hospital need and the experience of aapne jo kaya wo theek hai, that's depending on the personal experience. Somebody who just finished his bachelor degree comparing to person who has neurophysiology degree, or a patient with who has whose work is a even who has done house job or fellowship at CPS, or he want to come into neuro monitoring because it's, or even coming to US. Lot of people they coming from US for residency program. So I have applicant from Pakistan. They do internship with me because they're doing training with IOM internship, and that helps them in getting into the residency program. Dr. Mustafa, you want to say something? Sorry, just saw you message.
No.
Yeah.
Thank you very much, Doctor. I think I got the answer from your last explanation. That
Yes.
I was just suggest that because in Pakistan, we just have few institutions which are providing the neurophysiology trainings here. Even for the physicians, the fellowships are available for them, but their exposure is not in the high end procedures of the neurophysiology. So my just one simple suggestion is that if we can use these MT programs here, which is the BSMT programs 4 years, and after that, once they complete that one, because in MT program, in my program, the IOM is added as one of the course in the last semester for the 6 months, but the students does not have the full exposure. Clinical exposure is almost nothing there in that one, because we do not have the procedures here. We do not have the cases to give the hands on to the students. We're just giving them the lectures and the other things. My suggestion would be that if you can design some program which we can offer to our students post BSMT degree for a 6 months, just a condensed a crash program in the IOM for them, that would be very beneficial for them. Then they would be a very good resource for us here in Pakistan.
That's a very good suggestion. So that's the whole like plan. So if the patient, not patient, something, the applicant has a good like a MT degree, MT certification, or a background in neurophysiology, those will be very good candidate for those. Same thing. I think Dr. Mateen is saying the same thing.
Yes.
For the 6-month program, we should use the people who have some background in neurophysiology. So even when you go to US, you have 2 year you have neurophysiology fellowship in after neurology residency. You have
Yes.
only 2 months or 1 month or 2 months exposure in IUM. You're doing the fellowship is neurophysiology, but it's mostly clinical EEG or EMG nerve conduction testing, and only 2 months of intraoperative monitoring. And those 2 months you are watching the other people to do something, and most of the time is brain mapping or electrocardiography, but not enough to even understand what you are doing. So having a dedicated 6 month in IM is if like somebody with good IQ and knowledge and understanding can get benefit from that very quickly. So I think if you don't have any questions, we can stop here today. And I want to thank everyone on the panel. Thank you, Dr. Professor Arif, Professor Ahmed, Dr. Temur, Dr. Mateen, Dr. Mustafa, Dr. Talha, and everyone on the panel. And if I missed any name, Dr. Sajjad. So thank you very much to be here. So when we planned this, my understanding was there'll be like 10, 15 people. So so this is much more than we expected. And if you were on, someone was on the waiting list, so So we apologize because we didn't expect more than 100 people registering for the event. So we have, I think, 150 people registered for the event. So after 150, like after 100 people, so we have 50 on the waiting list. So that's why we created the YouTube link. And I'm going to upload this recording on YouTube, so you will have access to YouTube recording, hopefully forever. So hopefully we are going to get a more concise and more planning next talk, inshallah.
Thank you very much. Thank you, Professor Arif. Thank you, Dr. Jahangiri. Thank you, all the panelists. Thank you, all the attendees. Thank you very much. We'll be in touch.
Okay, assalamu
Have a
alaikum.
wonderful day.
Thank you.
Assalamu alaikum.
So,
Thank you so much, Fatal. Thank you, sir. Thank you so much.
thank you.